all on behalf of Magical Formula 2022 and its team. This conference, as you all know, is unique and hybrid, which aims to bring out magic in new non-surgical interventions and implementing them across the globe. Last year, this conference was virtual in 12 plus countries, and this year it is crossing 20 plus countries, which is huge indeed. Pre-COVID times, the importance of virtual connections were less, and we had to refuse lot of attendees as the hall capacity was of only 400 people. And now, believing in India's theme of Vasudev Kutumbakam, one earth, one family and one future, here we are with Magical Formula 2022. Without taking much of your time, I would like to invite Dr. Mohal Bankar, our proud host, to share his journey of professional career.
Thank you, Dr. Isha, for nice introduction, and I welcome you all in this Magical Formula 2022 live conference. And we have given tremendous response for this conference and registration from more than 20 countries, and we are really excited to deliver our academic work. And let me share my journey first. Start my presentation. So in the different part of career, I have taken many risks, and whenever I take the risk, I have one thought in my mind. It's a scary. So why the risks are scary? Because risk means sacrificing your time and energy, and we don't know that we will take we will get a reward or not. Reward in the sense of I will fulfill my need, I will fulfill my desire. I don't know whether this risk is fulfill my need or desire. So I always ask myself that are my sacrifice worth it? And let me show you which risk I have taken in my career. So I have started as a diagnostic radiologist practice in 2001, continue up to 2007, and started my private practice into the same area. But my private clinic was surrounded by urologists and nephrologists, so most of the work was from these feeding consultant, and work is limited to nephrology, kidney, prostate, and all these urologies, pathology. So I feel a little bit bored, and whether I put a very good diagnosis, but always credit goes to surgeon, because patient recognize the treating surgeon, not the radiologist itself. And it felt boring to me. So one fine day, I asked myself, can I do this for my entire life? My inner voice said no. So what to do the next? So I have to take the U-turn in my career and start something new, and which is really scary for everybody, because I have taken so many loans, and I have one child to feed at my home. My parents has different needs, and in all this scenario, if you take a U-turn and start from scratch, it's not an easy thing. And most of the time, people are afraid of the taking risk at this same point. But ultimately, I've started the new thing. I've taken this U-turn and done something new. So first case I've done for varicose vein in 2007, and later on I started my practice as an intervention radiologist. And people told me that you will not survive, but I will survive. I have some instinct that I will survive. 2009, I purchased the first radio frequency ablation machine for the varicose vein, and that is first in Gujarat. And later on in 2011, this is a gentleman, Dr. Waldemar Olszewski. I came to know in one conference that he's very good for treating the lymphatic edema, and he has invented the new treatment called silicone tube implantation for lymphatic edema. I invited him, and we have started lymphatic edema treatment into the Ahmedabad, but I was failed because he is from Europe. He's all the data is from the Europe, and the hygienic condition, European climate is different than our Gujarat. Our patients are not maintaining so much hygienic condition for the leg, and that's why our post silicone tube implantation into this leg, there are heavy incidents of infection, and then we have to remove all the silicone tube. And this was the first failure which I faced in 2011. Then in 2013, Professor Paul Zamboni and he suggested the new treatment for multiple sclerosis, and that is based on increased cerebral venous pressure. And if you put IJV stenting, or if you do the balloon plasty for IJV, it will dilate the jugular vein and it will reduce the pressure, and it will reduce the symptom of the multiple sclerosis. So we have done the couple of cases, but again it was failed because the hypothesis, which is based on increased intracerebral venous pressure, it is wrong. So then come in 2017, there are lots of vascular malfunction patients comes to me, and there was no specific treatment for vascular malfunction, whether you inject the sclerosant or glue, but it is a temporary effective because it just block the lumen, but the nidal part is still active. And surgery is not always successful because vascular malfunction itself is very embedded into the normal structure. So it's not possible to remove an entire lesion into the one sitting, and that's why I just search it out. Dr. Wayne Yeg is a pioneer for absolute ethanol embolization for vascular malfunction treatment. I went to USA, I learned from him and started doing the practice over here. And right now we are doing lots of cases from entire India. Then in 2019, the new technology came, the Vinasil for the varicose vein glue, and we are the first one to adopt this technology. And in 2020, when the whole India is into the, come to know about this intensive tweet from the Dr. Yuji Okuno from Japan, and he has find it out that into the joint, into the arthritis, there is a chronic inflammation going on into the joint, and there is a moya blood vessels, which is abnormal blood vessels, which is releasing the cytokines, inflammatory chemicals. And if you block these moya blood vessels, then you can reduce the chronic inflammation within the joint, and it will reduce the pain. And because of this my Twitter addiction, I find this new technique. Then we dig it deeper and deeper, and Genicular, we come to know about this Genicular artery embolization. And then me and Rosil have done the first case of India, and later on also done the for the shoulder, heel and tennis elbow.
We got the contact to come here. Number one, we have actually come here. We came here for the surgery for embolization and varicose veins. We got the message through social media, and a friend of us also just gave us a small clip of Dr. Banker, that what he does. We were actually blessed, we were lucky that we got that contact, and then we came here to Ahmedabad and we came to Ames Hospital. It was just amazing. They gave us the treatment of celebrities. I was actually shy about it, that it's just fantastic. My special thanks to Yashri, Miss Yashri, and then Miss Ami. They are two very supportive staff, and they did a fantastic job. I don't have any words to thank them. Dr. Banker is a gem of a person. He's a doctor who has got magic in his hands. In fact, he has cured my wife within 2 days without any pain or anything. She's now back to normal, walking like a young lady. That's it. And
thanks to Dr. Banker also.
And to Yashvi.
Yeah, all the staffs.
All the staff, they're all very
supportive and everything. The services they gave, I'm really blessed.
Yeah.
मी चारुलता भट जजीस बंगलो अहमदाबाद રહું છું અને મને ટીચરમાં લગભગ 10 વર્ષથી બંને ટીચરમાં દુખાવો હતો અને ડાબા પગમાં 2 વર્ષથી વધારે હતો. પછી મેં મારે ની રિપ્લેસમેન્ટ તો કરાવ્યું નહોતું એટલે ફેસબુકમાંથી મેં આ મોહલસરનો વિડીયો જોયો અને મેં આ પ્રોસિજર કરાવવાનું નક્કી કર્યું અને એમને એપોઇન્ટ કર્યા. એમણે બી પ્રોસિજર કરાવવાનું કીધું અને મેં પ્રોસિજર કરાવી અને આજે મને લગભગ મહિનો થયો. પહેલા મને ઘણો દુખાવો હતો, હું ચાલી નહોતી શકતી, રીટર્ન હતો નહોતો મારો, રાત્રે સૂતા પછી પથારીમાં મને બેસી રહેવું પડતું અને 2-4 કલાક કોકના સપોર્ટથી ચાલું પછી મને સારું લાગે. ત્યારે મને લગભગ ઘણો 80 થી ઉપર વધારે ટકા મને ઘણો ફરક છે અને આ મોહલસરને હું થેન્ક.
So basically we found our magical formula, and these are patient's word that these are really magic for us. Without any kind of operation, our knee pain and shoulder pain and other leg pains are disappeared. So till now we have done, me and Rosilla have done more than 500 joints for this Japanese treatment since last 2 years, and more than 12,000 procedures for varicose vein. Most important thing is not the numbers, but important thing is that we got a lots of blessing from the patients by preserving their knee joint from the surgery. So common prediction for me, many people told me that you will not survive, but I survived. I not only survived, but I thrived also. Who will send you the patient? This is a very common word from my ex-partners also, but highest number of patients treated by us. In era of this Mayodhana and PMJY, this treatment will not work, because in PMJY the knee replacement surgery is almost free. All the expenses will be taken care by government, but it works. And this very common thing, you will fail. Yes, I fail in many treatments, but failure has taught me the new way to success. So when I look back my journey, and I just think that why all these negative comment didn't work on me, because my hunger to do something new and to satisfy my hunger, I am ready to see as a foolish. So my dear my friends, take risk in your life, and it will be definitely helpful into your future to build your career. So stay hungry, stay foolish. Thank you.
Thank you, Dr. Mohal, and I'm sure it would have been an incredible journey. Our next speaker is Dr. Hitesh Rawal, who is owner of Sai Mangalam Clinic. He has special interest in color Doppler and musculoskeletal sonography. Apart from that, he is a golf player, great musician and a piano player, and has given many live performances. I would like to invite Dr. Abhilasha and Nisha Vyas to felicitate him. Okay, we are beginning with the presentation. So I would like to invite Dr. Hitesh Rawal on the dais.
Hello. Good morning, everyone. Now, today's our topic is why sonographer fails to evaluate varicose veins. So, common mistakes and false reports. Everyone makes mistakes, but it's important to think not to make the same mistake twice. So, obvious varicose vein in the patients, but reports are normal. Sometimes there is a false pattern and improper technique. Here is a case one. The report is given. left saphenofemoral junction shows competence and left and right is incompetence. So here we have examined the patient clinically in standing position. You can see the clear varicose vein in the right side below knee region, and also there is a varicose vein present in the thigh of left leg and as well as the below knee region. On color Doppler, if we put a saphenofemoral junction, we can see the reflux on the right side, which was written in the report. If we scan on the left side, there is also reflux, which is present on the left saphenofemoral junction, which is also incompetent. So what is the problem? Why it's missed? Because it was not done in the standing position. The position is important. Okay, you can see there is no obvious veins, dilated veins seen on laying down position. So in the second picture, in same patient, if we examine a standing position, there is varicosities in thigh and leg region. Now we are going to discuss second case. Patient is presented with the infective ulcers. You can see the discoloration of the skin, and patient has severe pain on the leg. Now Doppler report, saphenofemoral junction was competent, but there is no mention about perforators. So here, if we scan the Doppler for saphenofemoral junction, it is competent and showing the downward. So there is a large thigh perforator. You can see in the second image we have stored. So perforator is also important. Not only saphenofemoral junction is competent or not, but also see for the perforators like thigh perforators and anterolateral tributary refluxes. This is the second common mistake done by the sonologist. In third case, you can see the varicose veins, but report is normal. Why? Sometimes junction are normal, absolutely normal, but there is reflux from tributaries. So there are type 2 shunt. There are two types. One is open deviated shunt and second is a close. In open deviated shunt, you can see the N1 is the deep vein, N2 is the superficial great saphenous vein, and third one is we have seen the incompetent tributaries which arise from the superficial vein and drain into the deep vein. But in the closed shunt, there is a tributaries arising from the superficial vein and draining into the superficial only. So we have done the Doppler at saphenofemoral junction, which shows normal flow. Saphenofemoral junction is competent, is normal. If we trace great saphenous vein in the thigh region, we are tracing downwards. In second image you can see also draining into the superficial vein. So it is called as a reflux is not only from the deep vein only, but it will also come from the superficial vein, and it calls a type 2 shunt. So it is important to scan. So where it's costly learn from our mistake. So use proper techniques, and if varicose vein symptoms are present, then try to find out the source of the reflux. Some people makes mistakes, learn from the mistakes, but real sharp one learn from the other mistakes. Thanks Mohal sir, and thanks Health One for the team. So, thank you.
Now I would like to call Dr. Abhilasha and Nisha Vyas to felicitate Dr. Hitesh Rawal. Thank you, Dr. Hitesh. Varicose veins is one of the leading conditions and it requires proper management. Dr. Mohal Banker has performed 12,000 plus procedures for varicose veins, and also he is one to start glue embolization for the first time in Western India. I would like to call him on dais and share his knowledge.
Thank you, Isha, for nice introduction. So, what is the magical formula for varicose vein? This is a brief introduction of our hospital. Bankers Vascular Hospital has done more than 12,000 procedures for varicose vein, and is the first one to start these venous glue embolization treatment and many more other new advanced treatment into the Western India. So, as the time change, the treatment changes, and most of the time, the treatment is suitable into that era. Like if you see the old movies, and at that time we like that movies, but if after 10 years or 15 years if we see that same movie, then we just remember that how was the boring movies it was. So similarly, the treatment changes as per more and more research and data, more and more research on the disease and more data available. Each treatment is based according to the timing. The ultimate goal is to make the super hit Bollywood movie. Similarly, ultimate goal of the treatment is to destroy, to take care of the main reason for the disease. And for varicose vein, the treatment goal is to destroy the venous intima. The first one, it was started with the ligation stripping, then come the foam sclerotherapy, then come the laser ablation, and then come the RF ablation, and ultimately right now the glue therapy is most advanced treatment for the varicose vein. So now each treatment has some disadvantage, and that's why more and more research occur and try to eliminate the negative point from the previous treatment. So in the ligation stripping, there is a high recurrence and high blood loss. There is a risk of anesthesia. Then come the foam sclerotherapy, which has replaced the ligation stripping, but it is not effective for junctional incompetence because there is a high recurrence rate. Then come the laser and radio frequency ablation. It has too much post-operative pain due to thermal energy. When we are doing the laser and RF ablation, temperature goes up to more than 120 degrees Celsius into the RF and 600 degrees Celsius into the laser. This is the intraluminal temperature, and that's why there is lots of perivenous thermal injury, and it leads to the pain into the first 5 to 10 post-operative days. But then come these venous glue embolization, which has eliminated all these negative points for the previous treatment option. So how it works? So these really magic for the patient because we do the single needle puncture, then place this glue catheter near the junction, and everything is done under the USG guidance. And after the placing this catheter, we inject the glue, and whenever we inject the glue, these glue come into contact with the blood, and it will polymerize, and it will simultaneously we give the compression from the outer side. So the two wall of this reflux vein will be stick together, and the reflux will be eliminated. So this will seal the lumen, and once we treat some portion of the lumen, then we retract the catheter and we deliver the glue into the another part. Advantage: there is no postoperative pain, no bruising, return to normal activity much faster than any other modality, and no post-operative stocking required. And only she has done this before the Rashmi Rocket movie, and in Rashmi Rocket movie she plays the intensive role of athlete. So after doing this varicose vein with the Vinasil, she has done lots of athletic work also. So let's see what our patient says.
મારું નામ નીરજ નાનાવટી છે અને મેં ડોક્ટર મોગલ બેંકરના ત્યાં લેટેસ્ટ વિનાસિલ ટેકનોલોજીથી અમારું વેરિકોઝ વેઇનનું સર્જરી કરાવ્યું છે અને આ ટેકનોલોજીમાં મને સૌથી બેનિફિટ કે મારું સર્જરી થયું એ પછી મને ખબર જ ના પડી કે સર્જરી થઈ ગઈ. હું જે દિવસથી મારા રૂટીન વર્કમાં લાગી ગયો, કોઈ સ્ટોકિંગ્સ કે કશું જ પહેરવાનું નથી આવતું અને 1 મહિનો ઉપર થઈ ગયું મને તો મને કોઈ તકલીફ છે નહીં. પ્લસ મને 4 થી 5 દિવસનો નવરાત્રીનો ટાઈમ હતો અને ગરબા રમવાનો શોખ હતો તો સાહેબે મને એ પણ છૂટ આપી હતી કે તમે રમી શકો ને હું સારી રીતે રમી શક્યો. એટલે મને એવું લાગે છે કે આ ટેકનોલોજી સૌથી સારી છે જે બધાએ કરાવવી જોઈએ અને પ્રિકોશનલી જેને શરૂઆત હોય તો એને વહેલા કરાવવી.
So this is how all the patient says for this technique, and in conclusive remark, Vinasil wins the trophy of best treatment option available in the current era with superiority in patient's comfort, less recurrence, no post-procedure stalking, and early resume to day-to-day activity. Thank you so much.
Thank you, Dr. Mohal. Our next speaker for today's conference, Dr. Keyur Patel, is an interventional neurologist. He did his post-graduation from USA, and after coming back to India, his journey began with Neuro One Hospital in 2017. Later on, in June 2020, he started with Health One Hospital in East Ahmedabad. Since then, Health One Hospital and its family is constantly expanding and is successfully running its branches in Anand, Gandhinagar, Vastral and Shilaj. He aims to open other branches in order to provide quality and effective services to the patients. I would like to invite Dr. Keyur Patel on dais.
Good morning, everyone. Thank you, Isha, for a very kind introduction. Thank you, Dr. Mohal Banker, sir, Dr. Rosil Gandhi, and the entire team of Bankers Vascular Institute for organizing this wonderful academic feast. Again, warm welcome and happy Sunday to all the delegates who have joined us in this conference from across the world. I think more than 20 come back to the motherland, and then went for medicine and then neurology. Neurology was at Henry Ford Hospital in Detroit, and then I did a postgraduate fellowship in stroke and interventional neurology in Texas Stroke Institute in Dallas. So my personal interest basically was to just do mainly neurointerventional procedures. Again, neurointerventional procedure is one of the newest field in medicine. So it includes different procedures of brain and spine, including a cerebral and a spinal DSA, acute stroke, mechanical thrombectomies, endovascular aneurysm treatments with coiling, balloon-assisted coiling, stent-assisted coiling, fluid diverters, newer devices like intrasaccular devices, carotid and intracranial stentings, brain and spine, AV malformation and AV fistula embolizations, carotid cavernous fistula embolizations, venous sinus thrombolysis, stenting, among various other procedures. So this was what I trained for when I came in. And so once I came back, the original idea was to start and establish a one-stop solution for interventional radiology and a center of excellence for stroke care. Now, as you all know, stroke is one of the most prevalent but undertreated diseases in the world. Every 2 seconds, somebody suffers from a stroke, and every 6 seconds, somebody dies from a stroke. And time is of essence. So, when somebody is suffering from a stroke, every minute about 19 lakh brain cells die permanently. And those are the neurons that are not coming back. So, imagine 19 lakh brain cells dying every time you wait for a patient to be diagnosed and treated. So the need of the hour was to develop a center which was all-in-one, inclusive, which would have a CT scanner, an MRI, an ICU, and a cath lab, and an operational theater to again provide a 360-degree solution to treat the patient. So that is how it all started. Now, whenever you start any institution or a new business or a new model, you need to come up with the values. What are the core values that you are going to depend and build this business on? So, number one for me, because I was trained in US, I was used to this high quality infrastructure and the technology. So, we wanted high quality infrastructure and cutting edge medical technology. So, the struggle was to, get all these devices that our team was used to, being a QSA XL in the OT, a neuro navigation system, a pentero microscope in the OR for aneurysm, vascular malformation and aneurysm clipping surgeries. The machine that I trained on was this Philips FD20 cath lab with an intraoperative CT. And then again an NMR. So again, we got all these machines lined up together, and the first center that we started, an affordable center. So when you put in high quality infrastructure and cutting edge technologies, it's very easy to shoot up the cost. But in India, you have to make sure that you are still able to provide this sort of benefits to patients in a very, very affordable manner. So that is where the journey of Neuro One started. 16 and I shifted back to India, and 2017 is when we first started with our pilot institute, sort of a lab for us, where we learned the tricks and of the trade and the practice of Ahmedabad, which is way different. Trust me, it is way different than the practice in the US. So this was the first center. It was a 20-bedded setup with an ICU and a cath lab in Ahmedabad. And as time passed, as we learned more, we had added another unit right next to it and added a full-fledged radiology unit with a CT and an MR and a couple of more OTs with it. But when when we shifted gears, when we knew that Ahmedabad is growing concentrically. So Ahmedabad is growing around in circles, and typically if you look at Ahmedabad's development, it's around the roads. So initially it started with Relief Road, which is in the center of the city, then Ashram Road, then CG Road, then 132-foot Ring Road, then SG Highway, and now comes the time for SP Ring Road. The other end of the city is going to be very challenging. So we wanted to do something on the other end of the city, especially on the Ring Road. So connectivity is easy, and again, we didn't want to miss this growing opportunity on the concentric side. So that's when in 2020 in East Ahmedabad, we came up with a center called Health One. Now, so the journey from Neuro One to Health One was very interesting. We started doing a lot of other procedures than neuro. So the initial name was Neuro One Stroke and Critical Care Institute, because my primary training was in stroke and we only wanted to do stroke, but it didn't stop there. So we were treating a lot of brain and spine diseases. So we rebranded ourselves as Neuro One Brain and Spine Institute, and then eventually started doing a lot of cardiac, ortho, and other tertiary care, super specialty work. So it made sense for us not just to focus on the neuro part, but switch gears and encompass the entire health spectrum. So that's where the name Health One kind of suited us and came to us naturally because of the synergies with Neuro One. So Health One Ahmedabad in the east side in Vastral is a 111-bedded setup with 80 beds operational, 22-bedded ICU, a cath lab, as well as a CT scanner. That then led us to an issue of space, limitations at Neuro One, our old setup. So because of the growing pains, we were adding a new and exciting team of doctors with more and more procedures. We were finding short of space, so we expanded our setup a bit more west on the Ring Road again into this setup where we are currently hosting this conference. So it is a 151-bedded setup with 6 OTs, 1 cath lab, and a 32-bedded ICU. So that's when we thought, what else? What else can we do? So there are a lot of different ways where you can expand a hospital. So there are asset heavy models and asset light models. So asset heavy models where you own and operate the entire facility. It is usually a greenfield project. It takes a lot of capex, so that is capital expenditure, and then it takes a lot of time. You have to build find a suitable land, build a design, get it approved, and then construct the entire hospital. It can take anywhere from 1.5 to 4 years. So that's when we thought of going in the asset light model, where we would go and acquire ready hospitals, which were there are again 3-4 models that you can go about for that, which is one is a leasing and operating model, the second is a profit sharing model, third would be a revenue sharing model, and a fourth would be just a management just on a management basis. So that's when we went to Anand. Again, Anand was sort of a ready setup that we acquired. It's a 55 bedded setup with 2 modern OTs, a 10-bedded ICU, in-house CT scan, and all the radiology and pathology facilities. So that's where we are right now. So I would say the current strength, so we are right now in Ahmedabad on the 2 sides of Ring Road, and then Anand is live, and Gandhinagar is about to start very, very soon. This is the vision. This is where we want to be. There are certain places in Gujarat they've mapped out that would make sense for us in sort of a hub and spoke model, where you have basic hub models around Ahmedabad and spoke hospitals which would drain to those hub models. But again, think big. When you're an entrepreneur, you always have to expand your horizons and think outside of the box. Don't be a frog in the well sort of a phenomenon. So right now we have total 285 beds. So we have grown from 20 beds to 285 in the last 5 years, with 68 ICU beds, 11 OTs, 1 MR, 3 CT scanners, and 2 cath labs. And then by 2024, we are going to add around 460 more beds. So we are going to with a target of 750 beds by the end of 2024. So that's the goal. And So how does this happen? It does not happen alone. The most important ingredient in this magical formula per se is the team. It is the team. I am lucky to be surrounded by a core team of very dynamic, very dedicated and hardworking individuals who are really good on their own, but their strengths really multiply when they work as a team. It's sort of like an F1 pit. Today's, I think the Abu Dhabi race is today, and if you watch the race, the F1 pit stop, they do this tire change in 2 seconds, less than 3 seconds, almost every time. So it takes the whole team to do this. So that is the learning point. And the team does not happen inorganically. You cannot just start a hospital and say, I'll get the CEO from this hospital, this administrator from this hospital, this management guy from this hospital. It does not work that way. You have to build your own team. You can get the good people in the good spot, but you have to nurture them and mold them to do the role that you want them to do, and also learn from them about how to create a very dynamic organization. It should not be one way. It has to be bi-directional. Or for all the hospital owners or the doctors also, we're doctors, we are so busy and engaged and in our clinical practice, we forget the business side of it. It is again very, very important, especially nowadays, to know the business aspect of it. So you should know your data. When you know the number of procedures that you've done, as Mohal sir mentioned, he has done the highest number of varicose vein procedures, 12,000. He knows the numbers by the tip of his fingertip. You should know all the business data by the tip of your fingertip as well. You should know ALS, that is average length of stay. You should know AAPD is average admissions per day. You should know your ARPOB, which is average revenue per occupied bed. You should know your OBDs, which is occupied bed days. ROC is return on capital equipped. You should be updated with the NABH and the JCI guidelines so that you can update your medical infrastructure as well as the processes accordingly. You should familiarize. So today is the day of cashless treatment. Every patient wants to do cashless treatment, either private cashless with insurance or government. So when a doctor starts his practice, he's not aware of TPAs. When I came, for me TPA was TPA. I used it for thrombolysis. I didn't know TPA is basically an organization which does your third-party insurance clearances. So it was a news for me. So you need to know about PPNs, TPAs, PMJY, Ma Amrutam and Ma Vatsalya Yojana if you are doing those sort of patients as well. Again, keep updated with the statutory regulations, especially the fire NOC, especially the fire NOC. And you have to keep dashboards. So sometimes when we start our setup, we have to get all the licenses. So we do it all the time, right? But when they're about to expire or they get expired, we don't know about them. So you have to keep a dashboard. And in the dashboard, write down all the licenses and also put in the date of expiry and set up an alarm system in your Excel where you get notified before 6 months. So you have to start this process before 6 months. Otherwise, you will face issues of C form not being renewed or the fire NOC not being renewed. And then it can get into a bad medical legal situation as well. And again, work on your revenue cycle management. Medical business used to be a cash business, but now it's a credit business because of the cashless. So you need to work on the working capital and the revenue cycle management. Yeah, so I think it was a big topic, but I tried to cover it in a very concise manner. I think every one of those learning points can be a separate lecture of its own. But again, I'll be more than happy to answer any other questions via email or on our website or in person. So again, thank you.
To felicitate Dr. Keyur Patel. Thank you, Dr. Keyur Patel. It is indeed a great inspiration for many. Moving forward, I would like to welcome our next speaker, Dr. Ankur Shah, who is a consultant musculoskeletal radiologist at Sadbhav Imaging Center and Gujarat Imaging Center. He obtained training in musculoskeletal radiology at USA and Austria. He is also one of the joint editors of Indian Journal of Radiology and Imaging. I would like to once again invite Dr. Ankur Shah on the dais.
Thank you, Dr. Isha, for the introduction, and a very good morning to all of you. It is a pleasure to have you all on a Sunday morning, and to all our viewers who are all across the world. Good morning, good afternoon, wherever you are, if you are in the eastern part. Starting with this topic of the knee joint pain, I would like to show a few imaging tips for the knee joint. We know that knee joint is an extremely important joint because it has all our weight, and that is why any abnormality or any subtle pain in the knee joint is extremely disturbing. There can be various causes of knee joint pain. There can be traumatic causes, but we are more focusing right now on the non-traumatic causes of the knee joint pain. What are the imaging modalities that can help us in detecting the problem? It can be starting from the plain radiograph, which is always a basic tool, very much helpful in detecting certain abnormalities. But now with the more advancing imaging modalities, we have ultrasound, we have MRI, as well as sometimes CT scan that can also help. So plain radiograph is, as I said, always a basic tool. It gives us details about the joint space, about if there is any calcification or osseous abnormalities, like here there is reduction in the joint space in the medial compartment. We know that this is the classical picture of osteoarthritis. In severe cases, there could be even valgus deformities, which are very nicely visualized with just a plain radiograph. So it gives us a lot of information, though it is not enough. There are many things which are not seen with the radiograph, particularly the soft tissue structures. And that is where ultrasonography helps, particularly when the structures are superficial or when we are looking for the joint itself. So to see for the joint fluid, when there is synovitis or synovial effusion, ultrasound is a good tool. It is a good tool to evaluate the soft tissue structures which are superficial, like muscles or some of the ligaments. Like here we can see the fatty atrophy of the calf muscles. You can evaluate it very easily with the ultrasound. It is cheaper modality, easy to access. We can even do follow-up. We can do bilateral comparison. So these are the advantages of ultrasonography. Like here, there is a tendons which are around the knee joint. They can be very nicely or easily evaluated with the help of ultrasound. We can see the fluid in the bursa adjacent to the pes anserine tendons. But there are some limitations of the ultrasound. It does not evaluate the deeper structures, particularly the anterior posterior cruciate ligaments, which are very critical in evaluation of the knee joint. It cannot evaluate the meniscus completely. Maybe we can see just the outer part of the meniscus, but rest of the meniscus is not visualized with the ultrasound. And it has limited utility for evaluation of the cartilage and subchondral bone, which is again a very important aspect of the knee joint, because so many of the pain in knee joint, they comes from this part. So all these modalities might show us various findings. If particularly we are scanning a knee joint of a patient who is 60 or 65 years age, we are going to see some degeneration in the meniscus, we are going to see some changes in the ligament. But what we are concerned is, what are the pain generators? What is the reason that has led to the pain in that patient? So many of these findings might be non-specific and which may not have any clinical significance. So we need to understand whether it is ligaments like cruciate or collaterals, whether they are the muscles and tendons which are causing the pain. It can be meniscus, though meniscus has the neural part is only the neural innervation is only in the outer part of the meniscus. The inner part of meniscus is it does not have blood supply or the nerve supply. Or it can be cartilage and subchondral bone. Again, cartilage is devoid of blood supply, but when the cartilage loss is more, then it can lead to subchondral bony changes, and which can be extremely painful. Or sometimes it could be vascular structures or some neurovascular structures which are around the knee joint. So we need to identify which is the pain generator. Like here, if we see the MRI of the knee joint, you can see there is diffusely enlarged anterior cruciate ligament, which is showing like a celery stalk kind of appearance. We can see the fluid locules between the ligament fibers, and even there can be a cyst formation. And we know that this is the classical appearance of the mucoid degeneration of the anterior cruciate ligament, and this can be severely painful. Patient is not able to flex the knee. The pain is more while standing. So all these are classical symptoms of the mucoid degeneration of the knee joint. Sometimes it can be tendon, like here. We already have a talk on the jumper's knee, and this was a volleyball player. As you can imagine, there is a lot of jumping involved, and he had edematous changes involving the patellar tendon at its attachment with the patella, and this is the appearance of the patellar tendinosis or jumper's knee. So we know that this is the reason of pain for this patient. Meniscus tears, it can be of various types. There are different ways of grading those meniscal tear. I'm not going in all details, but it can be a vertical tear like here, longitudinal, it can be a horizontal tear, or sometimes it can be a displaced flap tear where the flap fragment, it acts as a loose body. So all these meniscal tears, they may not be painful, but particularly when the tear occurs in the outer part, which resultant the parameniscal cyst formation, because this is where the neural innervation is there. So this will lead to stretching, and it can result in pain to the patient. More importantly, what happens is once the meniscus is torn, it leads to significant increase in the degenerative changes in the knee joint. So as you can see here, there is a tear in the meniscus. Associated with that, there are areas of cartilage thinning and cartilage degeneration in the femoral condyle as well as on the tibial part, and resultant subchondral bone marrow edema like signal intensities. These subchondral bone marrow changes, these are the main reason of pain for the patient. When the tear occurs at the posterior root, like here, there is a posterior root tear of medial meniscus, the meniscus gets extruded, that comes out of the knee joint, and again there is increase in the osteoarthritic changes in the knee joint, which can lead to pain. So whenever there is no meniscus or meniscus is torn, like here, whether it is a medial meniscus or it is a lateral meniscus, there is significant rapid progression of the osteoarthritic changes compared to the side where the meniscus is present. So we can easily see here it is the medial compartment where the meniscus is completely torn, and you can see the full thickness loss of the articular cartilage with subchondral bone marrow changes, and same changes are also seen on the lateral compartment in another patient. So usually the medial compartment is most commonly affected by osteoarthritis, but when the meniscus tear is on the lateral side, then even the lateral compartment osteoarthritis can also be more severe compared to the medial compartment. Cartilage injury is a complex thing. There are a lot of stages and grades of the cartilage injuries, like here. It can be grade 1, which are very superficial lesions, or grade 2 lesions, which are little more deeper, or grade 3. All these 3 grades, they are limited to the cartilage. But when it is grade 4, that is full thickness cartilage loss with subchondral bone changes, this is the condition when the pain becomes more severe because of the involvement of subchondral bone. So we need to look at the details of the articular cartilage and its grading so that we can evaluate what is the reason for patient's pain. If it is full thickness loss with subchondral bone changes, like here, there is complete loss of the articular cartilage in the weight bearing part of medial femoral condyle, in some part of the lateral femoral condyle, medial tibial condyle, and there is complete loss of cartilage in the patella also, with significant subchondral bone marrow changes. And these edema like signal intensities, these are the cause of patient's pain. And once the changes are severe, we need to address that. We need to do some intervention or do something to help the patient. So to take home, there are various imaging modalities which help in the evaluation of painful knee joint. MRI is extremely useful modality which allows visualization of soft tissue as well as bony structures, and it is important to find out the pain generator and address that for the better management of the patient. Thank you so much.
Thank you, Dr. Ankur, and I would like to call Dr. Shraddha Makwana along with Kunjal to felicitate him. Our next speaker is consultant physiotherapist at Bankers Vascular Center. After clearing her bachelor's, she has done courses in advanced cardiac therapy from renowned institute like UN Mehta Hospital and has done Garbh Sanskar also. I would like to call Dr. Abhilasha Thakkar on dais for the physiotherapy techniques in knee pain. Hello all, hello team. Thank you so much Isha for introduction. I'll give some knowledge of physiotherapy for knee pain. Causes of knee pain are very common. Nowadays we can see many cases of knee pain due to many causes. Abnormal postures, patient used to develop abnormal postures, OA changes, many common, very common cause. Rheumatoid arthritis, post chikungunya pain, patient will get many joint pains. The knee pain would be more common in that. Injuries to ligaments and meniscus, as sir told. Post fracture conditions of lower limb, post operative, and many more. Here we can see structure of knee joint. Okay, types of pain. There are many kind of pain, but two main pain are resting pain and pain during activities. Okay, how physiotherapy management will work with knee pain? Physiotherapy will give so many benefits to pain, reduce the intensity of pain, improve joint stability, strengthening of knee muscle joints, improve range of motion, prevention of further damage. We can prevent osteoarthritis, rheumatic arthritis condition. We can secure our joint by doing physiotherapy. Okay, for pain management in physiotherapy guideline, we can do cryotherapy, ultrasound, IFT, interferential therapy. It will reduce your pain. And then you can give some key exercise, static quadriceps exercise, where you have to put one roll or some cushion below your knee and you have to press your knee. The counting of exercise will be starting from lesser count to more. Static hamstring exercise, second one is, it will strengthen your hamstring muscle, back thigh. Pillow press for adductor muscles, this will give stability and strengthening to your joint, mainly your adductor muscles. Vastus medialis strengthening, VMO strengthening will help in balance and stability, and more than that, it will get strength. Prone hamstring curl exercise, this will get your hamstrings strong again. Sitting quadriceps exercise, this will get your strong quadriceps and you will get stability also. More than this, gentle stretching, active stretching also you can do. You can get your physiotherapist for your passive stretching. Cycling, it's very healthy and very beneficial for your knee joints. It will strengthen your knee, improve stability. Swimming would be your best exercise for your strengthening of knee joint. Okay, now things to take care of. Avoid ground sitting. When you are having knee pain, any kind of, you have to avoid ground sitting. Your household work would be modified. Avoid Indian toilet. Many times, many houses don't have Western toilets, so start using Western toilet. Modify work pattern of your household work. More females used to work at home, so modify that work pattern. Take foot rest if you have prolonged standing. Teachers and site workers and many other professions who used to get prolonged standing, you have to take foot rest in between. Take small breaks from your prolonged standing. You have to take breaks. You have to alter your posture. You have to change your postures if you are going to get in same postures for a long time. Thank you.
Thank you, Dr. Abhilasha, for such an informative session. Knee pain is a leading problem across the globe. But what about the treatment options? Multiple, right? But what about the right treatment choice? Our next talk is by Dr. Rosil Gandhi on the latest treatment approach for the knee joint. He is an interventional radiologist and has done first case of genicular artery embolization in India, which is non-invasive procedure for treating knee. He has experience of more than 500 embolization procedures, and I would like to invite him on the dais.
Thank you, Isha, for the introduction. Good morning, everybody. we'll talk about genicular artery embolization. As we all know that knee pain is the leading cause of morbidity in old age patients. The spectrum of knee pain starts with the treatment spectrum starts with conservative management, that is NSAIDs. Pain, basically, that is, they are called the pain tablets. Then comes physiotherapy. But what after physiotherapy? If there is still pain, patients generally prefer to go for the knee replacement. But there is concern about the surgery and the replacement. So we have introduced genicular artery embolization in between the physiotherapy and the surgical part. Genicular artery embolization is a minimally invasive angiographic technique whereby we embolize the inflammatory vessels that supplies the knee joint and relieves the pain. What is interventional radiology? It encompasses many sub-branches of medicine. So we have minimally invasive treatment for more or less every subspecialty in the medicine. Any vessel, whether it is an artery or a vein, we used to occlude or embolize the tumors, we embolize the bleeding vessels, we embolize the varicose veins. Japanese started embolizing the inflammation in 2010 and 11. They published the first paper in 2014 by Dr. Yuji Okuno. So embolization, the treatment of inflammation by embolization is a newer thing. Embolization itself is not new. So we embolize the osteoarthritis of the knee joint, we embolize the plantar fasciitis, we embolize tennis elbow and frozen shoulder. And by embolizing, we help in relieving the pain. This is just a schematic diagram of the knee joint showing the various ligaments and the tibia and the femur. First important thing when a patient of knee pain comes to us is an examination. Clinical examination is very important. Tenderness is very important. Which part of the knee joint has tenderness, that is also very important. If needed, MRI of the knee joint is done. KL score of X-ray, it is very important for grading of the osteoarthritis. Some treatments are done in the early osteoarthritis, some treatments are done for the late osteoarthritis. As I mentioned, MRI and X-rays are very important. Angiographic image of the arteries supplying the knee joint. So there are 6 arteries that supply the knee joint. The cranial, it is the descending genicular artery. Then comes the superior lateral and the supromedial genicular artery. Afterwards, it is the infromedial and the infrolateral genicular arteries, and then there is recurrent genicular artery. We during the angiographic procedure of embolization, we cannulate each and every genicular artery. We do a detailed evaluation, and if there is any inflammation, if there is any hypervascularity, we embolize it. After proper evaluation, and if there is correlation between the tenderness and the osteoarthritis, if the osteoarthritis is early and moderate like grade 2 and 3, we take the patient for a genicular artery embolization for knee pain. We take femoral arterial access, that is in the groin, under ultrasound and fluoro guided with a 4 French sheath. 4 French sheath is 1.3 millimeter in diameter. So this sheath insertion is done under local anesthesia. The entire procedure is done under local anesthesia, where patient can see the entire procedure on the screen, and there is no need of suture or anything else or general anesthesia, because the incision is just 1.3 millimeter. So it's just a needle prick. Coming to a case, 58-year-old female had bilateral knee pain and right heel pain since 1.5 years, severely restricting her daily activities. Some areas were more tender. Basically, the medial knee joint space is the weight bearing area, and it is affected more. So generally the patients tend to have tenderness medially. This patient was diagnosed with knee osteoarthritis, and the marks given to the entire score. So in this we evaluate when the patient has pain on walking, on standing, on climbing stairs or climbing downstairs, on sitting to standing. So there this is a good scoring system, that is the international scoring system, WOMAC score. Radiograph is done and an MRI is done. So this was a grade 3 osteoarthritis with osteophytes are also seen medially. The joint space is more reduced on the medial compartment. This is the WOMAC score by which we evaluate every patient. This is also helpful for post embolization follow-up. We can see how much score has reduced, and thus it helps in objective evaluation of pain relief. So every patient before going to knee replacement, or every patient of knee pain, should be given an option of embolization after failed conservative management. Failed conservative management is failed management of oral medicines and physiotherapy for after at least 3 months. Earliest ambulation after 6 hours. After patient has underwent genicular artery embolization, patient can ambulate after 6 hours and do his routine daily activities. This is an angiographic picture. This is a descending genicular artery, and this is our microcatheter, that is 2 French. 2 French is less than 1 millimeter. This is our microcatheter in the descending genicular artery, and this is the normal artery, and this is the hypervascular blush. This is the inflamed area. Inflamed area is generally synovitis, is a generally synovial inflammation. That is because of the neoangiogenesis. What is neoangiogenesis? This is that they are abnormal vessels supplying the inflamed part. What does abnormal vessels do? They create neurogenesis also, and thus cause pain. So the root cause of osteoarthritis is not just wear and tear, it is also chronic inflammation. So we embolize the chronic inflammation, we embolize the hypervascularity, and thus by reducing the angiogenesis, the pain relief starts. This is infralateral genicular artery. As I mentioned earlier, we go in each and every artery super selectively and embolize the blush. This is again blush in the inframedial genicular artery. This is supralateral. This is the angiographic image of the artery of the lower thigh, that is the distal superficial femoral artery and the popliteal artery. So this is how the angiographic images look. These are all various images of the genicular arteries after and before the embolization. Japanese term the hypervascularity as moya moya. They are the abnormal vessels supplying the inflamed synovium. So there are many people who ask me whether after embolization there would be necrosis. I mean the joint would become dead or not. So no, nothing happens like that sort of. After we only embolize the hypervascularity, the parent artery or the original artery remains open. So there is no necrosis, or here has its complications, but this is very minimal with genicular artery embolization in a range of less than 1%. Immobilization up to 4 to 6 hours. Patient generally feels complete pain relief from the next day, but the complete relief occurs up to 6 weeks. They can start with normal routine activities, light exercise from the next day. So our experience is now of more than 500 patients with grade 2 and grade 4 osteoarthritis. 25 patients with various reasons had recurrence of symptoms, and we did repeat embolizations in some, and they have good relief. First patient was done in September 2020. Our study of plantar fasciitis is already on the route to publish, and we are compiling the data on this also, and we'll publish this soon. There are many people do feel, and we are doing a experimental therapy. So it is not an experimental therapy. There are various papers in various international reputed journals with good impact factor, and various papers are published right from 2014. This is published in European journal Circe about medial osteoarthritis and importance of embolization. This is a paper from US. saying the same thing, that genicular artery embolization can be used to treat pain secondary to osteoarthritis, and it demonstrates efficacy. Which patients are suitable? Again, this is a Japanese paper showing that patients with tenderness and medial joint pain are more suitable. This is a study with 2-year follow-up, again by the Japanese. It is showing embolization is a good treatment option for patients with lateral knee pain also. So, how it works? Hypervascularity of the synovium, it irritates the nerve fibers, nociception, and they are the source of nociception, and thus it causes pain. So, by reducing the vascularity, we stop this. This is a mid-term follow-up and MR imaging after embolization showing no knee joint necrosis, and just the synovitis that is reduced, but the knee joint remains the normal. So it is like magic. That is our branch, intervention radiology, and one of the patients follow-up who had undergone knee pain, embolization.
Hello everyone, I'm Anuja. I live in Chicago, Illinois. Since last 2 years, I was having intense pain on my left knee and bottom of my left foot. That was affecting my day-to-day life. I was not able to keep up with my daily activities. Every morning when I wake up, first few steps were very painful for me. Then we got to know about this non-surgical Japanese procedure, genicular artery embolism. So we decided our trip to India, and we met with Dr. Mohal Banker and Rosil Gandhi. They were very friendly, very helpful. They explained the procedure, and we decided to undergo the procedure. The procedure was very easy. The recovery period was very short. I was back from the hospital the next day. Recovery was not as painful as I thought it would be. During the procedure, I was able to see the images and the ongoing procedure on the screen all the time. The staff was very friendly. This procedure worked like magic in my life. I am back to being normal. I am able to exercise every day. I'm able to keep up with my daily routines, and no pain. This was a magic in my life. I recommend this procedure to anyone who is suffering from the pain, and it will work like magic in your life. Thank you.
Thank you.
Thank you, Dr. Rosil Gandhi. Moving forward, our next speaker is Dr. Ankur Shah. He has keen interest in musculoskeletal radiology and especially complex structures. He has also published various papers on the same, and I would once again like to invite him on the dais.
Thank you, and I'm glad to be here again. Actually, on behalf of Dr. Gaurav, who was supposed to take this talk, but unfortunately, because of some unavoidable circumstances, he couldn't be here, and I'm taking on behalf of him about imaging of the Achilles tendon. So, in 10 minutes, we'll be seeing briefly about some anatomy of the Achilles tendon, the imaging modalities, what is the difference between the normal and abnormal Achilles tendon, and what are the various pathologies which we commonly come across in Achilles tendon. We know Achilles is the thickest and strongest tendon of our body, the Achilles, right? So it has to be a strong one. The origin, it is in the mid calf. It is formed by the two heads of the medial and lateral head of gastrocnemius, and along with that the soleus joints, and they all three together, they form this tendon, which is the Achilles tendon. It has mainly two parts, the musculus-tendinous junction as well as the tendon proper, because the injuries, they occur at either of these parts. What are the imaging modalities? Just like any MSK part, we have plain radiographs, the ultrasound and MRI. CT again has very limited role, but the modality of choice is ultrasound or MR, and we need to decide which modality to use from case to case basis. Plain radiograph is mainly for the screening tool to look for any underlying bony pathologies like any fracture, or to see for the osteophytes or some calcification in the tendon. We can see some indirect evidence of the Kagar's fat pad, but otherwise the overall value of plain radiograph is limited. Ultrasound is a wonderful modality so far as the Achilles tendon is concerned, because it is a superficial tendon and we can see it very nicely with the help of ultrasound. The issue is it is more operator dependent, so you need to have a good person doing the ultrasonography. It understands for MSK ultrasonography, you need to understand the anatomy as well as the variants properly, otherwise it becomes difficult to scan. The advantage is that you can do a dynamic study with movement of the tendon, and we can evaluate the tendon at the same time, and it is easy to follow up or easy to do comparison also. So whenever we have doubt, we have the other leg also by the side, so we can compare both the tendons, and it is much easier to identify the pathology. MRI is excellent diagnostic tool, just like any other joint or musculoskeletal part. It has better soft tissue characterization, as well as it can give us details of the osseous abnormalities also, that it is not operator dependent, and of course we can get the multiplanar imaging, though at some added cost compared to the ultrasound. So which is the investigation of choice? Should we do an ultrasound or do an MR? Always it is better to discuss the case with the orthopedic surgeon or the physiotherapist or the treating interventional radiologist before doing the scan, so that we can decide which is better for a given patient and do accordingly. So as I said, both have their pros and cons, and we need to decide which would be better modality for a given patient or a given condition. The most abnormalities of the tender Achilles, they occur because of the trauma. It can be either trauma by the sharp injury like glass or knife injury, or the road traffic accidents. It can be because of the tractional injuries, or because of the overstretching of the tendon, or many of the times it can be because of the chronic abnormalities like repeated stress, which occurs particularly in the athletes or in the joggers or runners. And what we need to see is, we need to see for the tendon rupture, whether it is partial or complete. We need to see for the intrasubstance changes, to see for the hemorrhage or fluid collection or edema within the tendon, and the peritendinous changes like inflammation or fluid collection. So there is a classification of which is most commonly used is the Kuvada classification for the tendon tear, which also gives us idea about what would be the better management for a given condition. So if the rupture is partial thickness, which is less than 50% thickness, then usually the treatment is conservative, while complete rupture, if it is small one, then end-to-end anastomosis can be done. If the defect is larger, more than 3 cm or more than 6 cm, then we need to have a tendon graft or a synthetic graft. So ultrasound or MRI, they help in evaluation of whether the tear is partial or complete, and if it is complete, then what is the extent of retraction and what can be the further treatment which can be planned in a given patient. So the plain radiograph, it doesn't show much, but on ultrasound you can see the full thickness defect in the tendon, and we can easily measure the retracted part of the tendon, which can be a small one, or there can be a large gap like here. And as I showed, the further management is based on the size of the defect. MRI, it gives same information. You can see the torn retracted ends of the tendon. We can measure the distance between the two ends and again decide about the further management. So it can be a large area of defect, there can be fluid collections at the site of defect, and all those information are very easy to get with the help of MR. So again, ultrasound and MR, both these correlate very well. At least for the Achilles pathologies, the results are almost similar, and we can see the size of the defect very nicely. You must have heard about conditions, the names like tendinitis or tendinosis. What is the difference? The tendinitis, itis as it suggests, is inflammation, so it has to be an acute tendon, while tendinosis is a chronic condition. So sometimes the tendinitis, if it is not treated, then over a period of time it gets converted into the tendinosis. So the tendinosis or tendinopathy, the most common cause is over-exercise or the repeated trauma to the tendon, and not just the acute trauma. Particularly seen in athletes or basketball players, where there is enlargement of the tendon, there is disruption of the fibrillar pattern and increased vascularity within the tendon. And this is one reason why ultrasound, it even scores over MRI for evaluation of the Achilles tendinopathies, because MRI does not show the loss of normal architecture of the tendon, which is better seen with the help of MR. We also need to see what is the location of the abnormality, whether it is insertional, that is around last 2 centimeter, terminal to 2 centimeter of the tendon, or it is pre-insertional or mid part of the tendon. So as I said, for tendinopathy, the investigation of choice is ultrasound with color Doppler, which gives us details about the tendon. What do we see is usually the anteroposterior diameter, it increases more than 1 centimeter, and you can also see abnormality in the adjacent peritendinous soft tissue, that is the Kagar's fat pad, with increased vascularity. As you can see here on the ultrasound, the normal architecture of the Achilles tendon is lost, it is enlarged, heterogeneous, and you can even here see the insertional part of the tendon, which is thickened, and you can see increased areas of vascularity within that. That is the classical of Achilles tendinopathy, which can be either non-insertional or insertional, as in this case. MR, again, it showed same picture. There is enlarged tendon in the distal part. You can see areas of hyperintensity on the fat suppressed T2 weighted or proton density images, and adjacent edematous changes in the Kagar's fat pad also. So both the modalities can give us excellent details of the Achilles tendon abnormalities. A few other abnormalities which I won't be going in the detail to lack of time, but they are Haglund syndrome, like here. There is an osseous prominence which leads to the Achilles tendinosis with partial tear of the tendon. There can be different degenerations like the mucoid or the hypoxic degeneration, which are non-traumatic, but the tendon is enlarged and shows areas of the fluid intensity within. There can be xanthomas within the tendon, which shows significant enlargement of the tendon, and sometimes other conditions like rheumatoid arthritis or gout can also affect the Achilles tendon. So to take home, understanding of anatomy and imaging modality is extremely important for the Achilles tendon. We need to identify the difference between the normal tendon and the abnormal tendon. Always discuss what do you want to look for to decide the proper imaging modality, and so far as possible, try to follow up the patient with the same imaging modality so that we can give the comparative results. Thank you so much.
Thank you, Dr. Ankur, for such an informative session. Our next speaker is Dr. Dimple Parmar. She passed her Bachelor's of Physiotherapy from JG College of Physiotherapy, which is located at Ahmedabad. She has done her certification in basic life support and has also participated in various conferences. I would like to invite her on the dais.
Thank you, Dr. Isha. My topic, physiotherapy for Achilles tendinopathy. What is Achilles tendinopathy? As already previous speaker said, it is the degenerative disorder of the tendon which changes in the collagen fiber structure. It is mainly characterized by the pain and swelling in and around the tendon, and it is mainly arising from overuse. It is also seen in the middle-aged overweight patients, and now it is not common in the athletic person. It is also seen in the non-athletic persons. Athletic ratio is 2/3 and non-athletic ratio is the 1/3. Clinical features. So first of all, pain. Pain is the hallmark symptoms for the Achilles tendinopathy. Pain, morning pain is the common. Then after the some steps reduces, and after then the physiotherapy management. So for main aim and goal for the physiotherapy management is to improve the muscle and tendon capacity to manage load. So first of all, we have to focus on the reduction of the pain. So cryotherapy. Cryotherapy, which helps into the reduction of the pain, it has the analgesic effect. It also reduces the metabolic rate of the tendon. Then the ultrasound. Ultrasound is the electrotherapeutic machine. Low intensity pulse ultrasound has been used. It helps into the decrease the swelling and improve the tendon healing. Deep friction massage. There are many massage techniques are available, but deep friction massage are very helpful for the Achilles tendinopathy. It reduces the pain and improve the extensibility of the tendon. Then exercises, mainly 3 exercises for the isometric load for the Achilles tendinopathy. So first of all, isometric loading exercise, then isotonic loading and energy storage loading exercises. So isometric loading exercise. Isometric loading exercise are used in the initial stage. It releases some amount of the pain. It simultaneously maintaining some baseline strength. It's also increasing the power of muscle, like seen in the picture with the help of the ball isometric exercises. Then the isotonic loading exercise. Isotonic loading exercise are used when the some amount of the pain and the tendon irritability has been reduced. NPRS scale ratio is less than 5 out of 10, then it is performed. It's improve the range of motion and the mobility. Like normal range of motion and progression with the resistance band and the after some strengthening exercises, like example is the sitting calf raise with the load. Then the energy storage loading exercises. Its name already suggests it's demanding of the energy. So it helps to regain its capacity to absorb, release energy via the stretch or shortening cycle. Examples are the double leg hoop, single leg step hopes, coach with the activation band, like seen in the pictures. Example, double leg hoop. Then the stretching. Stretching used when the presence of tightness of the muscles, like seen in the pictures, stretching of the muscles. Then the mobilization. Mobilization is used when the assessment reveals joint restriction. First of all, talocrural joint mobilization for the dorsiflexion limitation, and then the subtalar joint mobilization for the varus and valgus limitations. Then the tapping. Rigid tapping has been used. It decreases the strain and it helps in patients who suffering from altered foot postures. Then the orthosis. Many types of the orthosis are used, which helps who patients suffering from the anatomical posture of the foot. Conclusion: 90 to 95% of the Achilles tendinopathy patients can get rid of pain with the help of the physical therapy. Thank you all of you.
Thank you, Dr. Dimple. Our next speaker has special interest for non-vascular interventions. He also has gained much of experience in taking difficult biopsies. He has expertise in doing tips. Besides complex procedures, he is also helping patients of heel pain and ankle pain to get off it.
And now embolization for inflammation. Our previous speaker mentioned 90 to 95% of the Achilles tendinopathy can be treated with physiotherapy. So we are here for the rest 5%. This is a novel intervention that could transform clinical care and shift the current paradigm from treating non-malignant musculoskeletal pain. So this is called TAE or TAME because we are embolizing the microvasculature. We are embolizing the capillaries. We are not closing the parent vessel with coils. We are just embolizing the hypervascularity or the moya blood vessels. Chronic musculoskeletal pain is a major public health burden. And identifying a safe, effective and durable intervention. NSAIDs help until you take NSAIDs. Physiotherapy also helps until the patient continues doing the same physiotherapeutic management at home or under a trained physiotherapist. But what afterwards? Embolization gives a durable treatment for a long term because effective pain control helps in major improvement in quality of life and improved mobility. As I mentioned, the first part is NSAIDs. They are relatively inexpensive and non-addictive. They are the current mainstay now as a first choice. But there are issues with that also. They cause acidity and the gastric issues. So we have to give pantoprazole and other like-minded drugs for that. There are safer alternatives also, but opioids can have risk of habituation and addiction. For knee osteoarthritis, there are repeated intra-articular corticosteroid injections. Also for steroid injections in the tendon have been mentioned to be useful. But they cause thinning of the tendon or thinning of cartilage. NSAIDs also interfere with the healing process. So we come up with embolization. Because osteoarthritis and tendinopathy, they are not just wear and tear disease, they are result of chronic inflammation. There is proliferation of abnormal vessels and it increased migration of immunoeffector cells to that area, which leads to the cartilage or the tendon destruction and perpetuation of local inflammation. So embolization targets the hypervascular synovium physically and medically debulking the pathogenic synovium by causing its necrosis. Neurogenesis can be upregulated in parallel with angiogenesis, which is contributing to the pain. So we see the angiogenesis, the moya blood vessel or the hypervascularity on angiography. But what we not see is the neurogenesis. By angiogenesis there is neurogenesis also, and neurogenesis causes pain. So by embolizing by treating the angiogenesis, we are treating follow-up MRI after embolization. It shows resolution of tendinosis. So we have an objective report also that embolization helps. This is the ankle vascularity surrounding the ankle supplied by the posterior tibial, anterior tibial. Achilles tendon is generally supplied by the branch of posterior tibial artery. Middle-aged female, pain in posterior ankle since 2 years, hampering day-to-day activities, not relieved with conventional conservative management. We take a femoral puncture, as I mentioned earlier, with a 4 French sheath that is 1.3 mm in diameter under local anesthesia. So there is no incision, no suture. So it is a pinhole technique. So this is a angiography image of posterior tibial artery, the artery supplying to the, we embolize it. So superselective cannulation of the feeding artery is done. This is post embolization. Rest of the arteries are patent, they are open. So there is no chance of ischemia or necrosis. And you can't see a hypervascular or moya area, inflamed area here. So we have treated the hypervascularity. We immobilize the patient for 4 to 6 hours. Generally patients have complete pain relief from the next day or more than 70% pain relief, and within 6 weeks they get a complete response. Routine activities are allowed from the next day. So we propose to keep the embolization as a treatment option after failed conservative management and before surgical trial for Achilles tendinopathy also. Our experience for Achilles tendinopathy, just Achilles tendinopathy, is more than 10 patients with complete response in all. But embolization for inflammation, for knee pain, for frozen shoulder, total we have crossed more than 500 joints. Recent article of March 2022 by American College of Rheumatology, embolization for chronic musculoskeletal pain. They have done a systematic review and it is effective for chronic refractory pain. So this is the content of that article. They have used for multiple sites: knee, elbow, shoulder, frozen shoulder and trapezitis also. Thank you.
Thank you, Dr. Rosil. Our next speaker is Dr. Joy Shah. Dr. Joy has special interest in cross-sectional imaging and non-vascular interventions. He has expanded more than 5 Medimex imaging branches. He is a great cricket enthusiast also. I would like to invite him on the dais.
Okay. Good morning, everyone. Thank you for having me here. So today we'll be discussing the imaging techniques in frozen shoulder. Mainly, just going ahead, I would like to tell you that it's mainly a clinical diagnosis, and obviously to stamp it, imaging is very sensitive and specific, especially the MRI. So quickly moving forward. What is frozen shoulder? So it is a condition characterized by thickening and contraction of the shoulder joint, capsule and the surrounding synovium, and then there is buildup of the scar tissue which restricts the movement of the joint and resulting in pain and limiting the motion. It's more commonly found in female population. 5th to 6th decade is the more common age group which is affected, and comorbidities such as diabetes mellitus and hyperthyroidism. In such cases, the presentation can be also early. So mainly there is pain and restricted motion, especially the external rotation is affected in these patients. Quickly going, there are 3 stages clinically. The first one is the freezing stage, where the pain is the predominant feature and motion slowly picks up in getting affected. Then there is the frozen stage, where there is fibroblastic activity, the pain reduces and the range of motion decreases further. And then there is the thawing stage, which lasts up to 3 to 4 years in many patients, and it is gradually there is return of the motion. So what are the imaging modalities used for frozen shoulder? MRI and MR arthrogram. So MRI is the gold standard. USG can be useful to diagnose and correlate clinically. Plain radiography and CT scan are not useful for diagnosis or staging of frozen shoulder. And conventional arthrogram, which was done previously before the MRI and USG, but that is all historical and obsolete now. So before going further, let us quickly just see a few imaging spaces which we have to visualize both on MRI and USG in frozen shoulder. So the rotator cuff interval, that is the main region where the fibroblastic activity scarring happens. So these are the 2 images of a normal MRI. This is a T2 weighted sagittal image and this is a T1 weighted image. So this is the rotator cuff interval. It is bounded anteriorly by the coracoid process, superiorly by the supraspinatus and inferiorly by the subscapularis. So here is this rotator cuff interval, where normally you will find nice fat. You won't find any soft tissue here. You will see fat. Then there will be visualizing this ligament, that is the coracohumeral ligament. And then here with the short arrow, what you see here is the long head of biceps tendon. So these are the 3-4 structures which are nicely going through the rotator cuff space, and there is no soft tissue or scarring here. Similarly, here on the coronal image, you can see the coracohumeral ligament. Another space which I would like to tell you is that the axillary pouch, distended, this is how it would look, a normal axillary pouch. So on MRI, what all things will we see? So in these 2 spaces, whenever you see any abnormal soft tissue thickening or any abnormal signals in the rotator cuff interval or around the biceps anchor, then you should raise a doubt if there is a clinical suspicion. Then there is a subcoracoid triangle sign. So whenever the fat which I told you in the rotator cuff space interval, if that is not clear or it is hazy or there is soft tissue, then that sign is positive. So that is very sensitive and specific. Direct visualization of the coracohumeral ligament, if it is thickened more than 3 mm, we consider it to be positive. Also, as I told you, in the axillary pouch, if there is joint capsule thickening more than 3 mm or any hyperintense tissue or signals, then you should raise a doubt. And in case you happen to do post contrast MRI or contrast MRI, then you will see this scarring tissue to enhance. Generally we don't do it, but if you do, then you will see enhancement because of the fibroblastic activity and the scarring. So here is an image. This is a T2 weighted sagittal image, and as you can see, there is thickening of this ligament, that is the coracohumeral ligament. If you can see the fat which is supposed to be hyper intense over here, that is all looking very dirty. Even surrounding the biceps anchor, there is dirty looking tissue. So this is thickened coracohumeral ligament, which is very sensitive for adhesive capsulitis. Another is the subcoracoid triangle sign. As I told you, beneath the coracohumeral ligament and between the coracoid process and the tendons, there will be a nice fatty tissue which will be seen. In case if you don't see this fat, and if it is adhesive capsulitis or frozen shoulder. Another, this is a normally distended nice axillary pouch. You can see thin inferior glenohumeral ligaments. If you see thickening of this glenohumeral ligament, or if the patient has joint diffusion, or you have performed an arthrogram, and if you see it is not getting distended, then again it is quite sensitive and specific for adhesive capsulitis. Again, this is axial images taken at the level of the inferior glenohumeral ligament or the axillary pouch, and you can see that there is soft tissue and hyperintensity. So these are again diagnostically helpful for adhesive capsulitis. If you happen to do a arthrogram, because the space it cannot distend, so there will be a leakage of contrast outside the joint space, as seen in these two cases. So this is on MR arthrogram. This is what you will see. Before, when there was no MRI, people used to do conventional arthrogram, which is not performed, but you can see here in a patient with adhesive capsulitis, the inferior this axillary pouch, it is not getting distended by the arthrogram, and so what is happening, even this space which is supposed to be the rotator cuff interval, it is also not getting filled. So probably there is scarring over here, and the contrast which is given is getting leaked outside the joint space. So same like MR arthrogram, this is conventional arthrogram on X-ray, not done now, not needed because we have MRIs. USG, the same things. You can see a thickened coracohumeral ligament. You can see thickening of the axillary pouch. Another sensitive sign on USG is that in the rotator cuff interval, if you see anything surrounding the biceps tendon which is looking dirty, and if you put a power Doppler, if you see some vascularity because of increased vascularity which is supplying that scar tissue, then it should always raise a doubt of adhesive capsulitis. And if you happen to see in dynamic USG scanning, if the supraspinatus is not moving smoothly, then again that is a sign of adhesive capsulitis. So this is a case where they have demonstrated thickening of the coracohumeral ligament. Another case, they have scanned this USG is at the level of the axillary pouch. This is the inferior glenohumeral ligament. So this is the left side is the abnormal one, and this is the normal one. So you can see here on the normal side it is not thickened. Here it is thickened. If you so this is another image where this is the long head of biceps tendon. Surrounding it there is dirty looking echoes, and if they have kept a power Doppler which is showing increased vascularity. So this is useful in diagnosing. So what are the key points? Mainly the first it is a clinical diagnosis. Imaging can be used to exclude other articular and rotator cuff pathologies, and most common findings which we see are thickening of coracohumeral ligament and the inferior glenohumeral ligaments, and also the rotator interval fat pad obliteration in MRI or in USG, as I told you, surrounding the biceps tendon. If you see the fat is not looking good, so that's a very specific sign. And ultrasound, obviously, in non-vascular interventions for injecting steroids or any hydrolysis, it can be used. Thank you.
Thank you, Dr. Joy, for such an informative session, and I would like to invite Dr. Dimple along with Rinku to felicitate Dr. Joy. Our next speaker is Dr. Shraddha Makwana. She has done her Bachelor's of Physiotherapy from CM Patel College of Physiotherapy and has just passed in 2022. She is an aspiring physiotherapist and has interest in musculoskeletal physiotherapy. I would like to invite her on the dais.
Good morning, everyone. I'm going to present physiotherapy for frozen shoulder. So, first of all, what is frozen shoulder? Frozen shoulder is a common disorder that causes pain, stiffness, and restricted range of motion. The resulting disability can be serious if it's not treated, and it's affect mainly people after ages 40 to 60 years, and women are more affected than men. These are the causes of the frozen shoulder. Now there are three stages of the frozen shoulder: freezing, frozen, and thawing. First one is very initial stage in which patient having more complaint of pain followed by restricted range of motion. Second one is a frozen more developed stage in which patient having complaint of more restricted range of motion but pain is in a reducing mode. And third one is a thawing, which is a recovery stage. So what are the chief complaint of the patient? So main complaint of the patient is a pain. Patient having complaint of activities of daily living like hair combing, shirt wearing, overhead activities, and patient having more complaint of the sleep disturbance during night due to pain, and restricted range of motion due to stiffness or pain. So what is the rehabilitation approach? So first we are targeting to pain. We are starting with the cryotherapy. Cryotherapy stands for the ice pack. We frequently use ice pack over the painful area, so it's reduce the inflammation and reduce the pain. We'll use hot pack over the painful area, so it's reduce the blood circulation. Interferential therapy will use for more muscular part is involved, and ultrasound therapy will use when we have to heal our tissue, and TENS is for reduce pain. Now we have to improve our flexibility. So first of all we stretch our capsule, because capsule is the more involved in the frozen shoulder. So we have to improve capsule stretching. So first figure shows posterior capsule stretch, second one is inferior capsule stretching, and third one is anterior capsule stretching. Now we have to stretch our upper chest muscles. So first figure shows passive stretching of the pectoralis major muscle. Second one is actively stretch pectoralis major and minor muscles, and third one is actively stretch trapezius muscle. Lastly, we have to improve our range of motion. So we start with the mobilization, passive movement, assisted exercise, active exercise, and resisted exercise. So first we do mobilization, in which we give glenohumeral inferior glide for improved abduction and posterior glide for improved flexion. Now patient have to do assisted exercise, in which first figure shows a finger ladder, in which patient have to do flexion and abduction movement by using this finger ladder, and second one is patient is doing all circumflexury movement of the shoulder joint by using this shoulder wheel. Third one is a wand exercise. Patient is doing all the movement of the shoulder joint by using any kind of wand or stick. Fourth one is a pulley exercise. Also in this, patient is doing all the movement of the shoulder joint by using pulley. Now patient have to do all the movement by themselves actively. First one is a pendulum exercise, in which patient have to lean over the table and do pendulum movement of the shoulder joint, like a circumflexury movement, flexion and extension movement, and all the movement of the shoulder joint done by the patient actively. Now we have to improve our stability of the scapular muscles. So these are the isometric exercise for the scapular muscle. Lastly, patient is doing resisted exercise by available range of motion when patient have no more pain. So all the movement of the shoulder joint are done by using this stretch band, or they can use dumbbell as well. So by doing all this physiotherapical management, 80 to 90% of the patient are recovered from this frozen shoulder. Thank you so much.
Thank you, Dr. Shraddha. As we all know, shoulder joint is a very complex joint, and to achieve recoveries in shoulder joint, it takes a prolonged period of time. Frozen shoulder is a condition which may get cured over the period of time by physiotherapy, but what if not? I would like to invite Dr. Mohal Bankar for treatment options in such cases.
So thank you, Isha, for nice introduction. And Rosel has already told that we are here to remaining 5 to 10% of cases who is non-refractory for the physical therapy, and definitely who wants to avoid this complex surgery of the shoulder joint. So basically, shoulder joint is a very different joint from other joints of our body, because it has a very small socket, and it is purposefully made because more and more mobility is given to the shoulder joint. And this joint is supported by so many muscles and tendons and capsules. So we are now talking about this adhesive capsulitis, which is a chronic inflamed condition of this shoulder joint capsule. So what to do if physical therapy fail? And this guy called Dr. Yuji Okuno, he has published a first paper way back in 2013, and he has shown to the world that frozen shoulder can be treated with this new technique called frozen shoulder embolization, and by doing this we can reduce the pain of the patients. So first case, this is a diabetic patient, severe night pain since last 2 years, and he himself is a very good athletic player, basketball player, but not able to play sports because of the joint pain. And we have done this frozen shoulder embolization. These are pre-angiographic image, and it's classically visible that all these vascular blush, these are moya blood vessels, which is seen in these pre-angiographic pre-embolization angiographic images. And with the small microcatheter, we are injecting this embolizing particle, and these particles are a very smaller size, which it blocks only moya blood vessels. Normal parent vessels are intact. It will not, this embolizing particle will not block the parent vessels. And there is a post embolization angiographic image. You are able to see the main artery, parent artery is intact, but all this vascular blush is disappear, which is classically seen into these pre and post images. And by doing this, we get the smile of the patient, and these are really thriving force for us to reduce the pain and get smile back on the patient face. And pain is completely gone. He is able to sleep after 2 years, sound sleep, because of the severe night pain. He was not able to sleep properly and started playing the games. Now the second case is a gym injury. He's developed the frozen shoulder after gym injury. Severe pain in gym, later on pain increases and frozen shoulder develops, and abduction was affected, less than 90 degree of abduction possible. And we have done this frozen shoulder embolization, and these are vascular blush over here, and post embolization the parent artery is intact, but the vascular blush disappear. And again the pain reduces by 70%. Now restricted to certain movement and regain abduction completely. Now this is the third case. This is a very interesting case because of the recently we have seen the COVID-19 pandemic, and lots of COVID-19 vaccine administered into the from huge population, and because of the faulty injection of this COVID-19 vaccine, which is given into the shoulder joint capsule, and it leads to the adhesive capsulitis. And there is the same such patients, and it has given us a specific term. It's called SIRVA. There is shoulder injury due to the vaccine administration. So patient develops shoulder pain after COVID-19 vaccine, and this is a very common complaint if one inject vaccine into the shoulder capsule. And see, these are pre-angiographic images. These are anterior circumflex humeral artery, and you are able to see over here. These are shoulder joint capsule, and particularly the injection given into this site, and there is a vascular blush over here. And post embolization, the vascular blush is disappear. So in this case, pain reduces by 100%. So in conclusion, if physical therapy failed, then don't jump to operative options. New promising treatment of MSK joint pain embolization works well into the joint pain. Thank you so much. So now I would like to invite Dr. Keishi Fujiwara. He is an intervention radiologist from Japan, and a part of all his academic achievement, he is a very good friend of mine, and he has helped me a lot. Whenever I am confused, whenever I have some problem for results for this pain embolization, I always consult Dr. Keishi, and he guided me a lot for improvement of our technique also. He has helped me a lot. So Dr. Keishi is joining us from Japan.
Okay. Full screen আছে
Hi, Dr. Keishi. Are you able to hear us? Unmute. Hello. Hi, Dr. Keishi. Are you able to hear us?
કોઈ બી એમનું મ્યુટ છે એમનું મ્યુટ છે ટેલ હિમ કે જસ્ટ અનમ્યુટ યોરસેલ્ફ
Unmute your mic, Dr. Keishi. Yeah. Yeah. Hi, Dr. Keishi. How are you? આપણું મ્યુટ છે કે શું છે ભાઈ? Now able to hear you? Hello?
Okay. Okay.
Yeah,
okay.
yeah. Hi, Dr. Keishi.
Hi.
Yeah.
Nice to meet you. Hi.
Yeah. So I've just given you an introduction that I've learned very good technique for this MSK embolization, and many times when I got stuck up in few cases like heel pain and many more, you have saved me from Japan. So
Thank you.
Yeah.
Thank you for coming.
So I welcome you from our Indians and Indian community of IR, and let's start your talk of MSK embolization.
Yeah.
Yeah.
So,
Yeah.
can I start?
Yeah, you can start.
Okay. Hi. Namaste. Hi. My name is Keiichi Fujiwara, and I'm an international radiologist here in Japan.
So thank you for inviting me. Great meeting, and I'm really excited and feel so honored. So I'm so appreciate Dr. Mohar, banker. I'm really appreciate you. Thank you. So let me introduce myself. So my name is Keiichi Fujiwara, and I'm an interventional radiologist and specialized for MSK intervention like US guided injection or MSK embolization. I opened my own clinic, and which specializes MSK intervention and varicose vein treatment. Maybe it's similar to Dr. Mohar's clinic, but your clinic is bigger and more beautiful, I guess. Okay, and then so I have a Twitter account. So if you can, if you're interested, please check my Twitter account. I sometimes post about MSK intervention. Okay, so today I'm talking about three topics. No big deal. First, theoretical background of MSK embolization and MSK embolization procedures. Finally, a little bit case presentations. At first, I explain about background. So, what is MSK embolization? So, this treatment method improve pain by embolization by abnormal nerve vessels associated with inflammation like knee OA or frozen shoulder or plantar vasculitis, something like that. So, do you think why does MSK embolization improve pain? Last year, important paper was published to answer the question. This paper is basic research for MSK embolization for rat model of frozen shoulder. This is can you see? This is thoracoacromial artery. In frozen shoulder, abnormal stain is identified compared to normal rat. This is histopathological findings of synovial membrane of shoulder joint 1 week after treatment. Compared to control, in TA group, microvessels and inflammation cells are decreased rather than before. It's a significant difference between them. Furthermore, physical activity in TA is also better than that of control. In another study, in this case of the frozen shoulder, not only microvessels, bruised microvessels have a red circle is nerve fiber have increased compared to control. So the answer of this question is by embolizing abnormal nerve vessels, inflammatory cells and nerve fiber are reduced, it can improve pain, we think. These are various diseases which confirm the relationship between abnormal nerve vessels and nerve fiber ingrowth in histopathologically. A lot of disease, lateral epicondylitis, Achilles tendinitis, of course frozen shoulders, or patellar tendinopathy, a lot of disease. Okay, next I explain MSK embolization methods. This is the whole process of procedures. First, we perform local anesthesia and US guided puncture. Puncture site it depends on the cases. For example, in the case of shoulder, site is radial artery. In the case of knee, site is antegrade femoral artery. After that, insert the catheter through the vessels, infuse embolic material. After embolize all target vessels, remove the catheter. Rest time is only 1 hour in our clinic. Discharge on same days. Devices we use 3.3 French angiographic catheter and 1.7 French microcatheter. Tip shape is dependent on the cases. Mostly we use headhunter type like this catheter. Regarding embolic material, mostly we use imipenem statin. This is approved as antibiotics in Japan. The characteristic of imipenem is slightly sorbent to water and temporary embolic material. Embolic effect is 10 to 20 minutes. Sometimes we use embosphere. This is permanent material. This is US guided puncture to radial artery. I think single wall puncture is better rather than Schrödinger puncture method. This is because we can avoid hematoma and artery spasm. Only single wall puncture. In the case of knee osteoarthritis and Achilles tendinitis, we perform antegrade puncture to common femoral artery, induce with wire induced to superficial femoral artery. Regarding the insertion catheter to vessels, IRists usually perform over the wire technique. However, the vessels treated with MSK embolization, so it's so thin, so easy to spasm. So I recommend non-wire technique. So I'm sorry. So with the angle type microcatheter, so with that wire, we can select the vessels. Again. Like this. So, next, do you think which artery is the target? In the case of shoulder, 6 vessel is important. Scapular artery, thoracoacromial artery, coracoid branch, circumflex scapular artery, anterior circumflex humeral artery, posterior circumflex humeral artery. Among them, so number 2, thoracoacromial artery is most important, I think, because it's feeder to rotator interval. Furthermore, number 1 scapular artery has 5 anatomical variations. This is IMPRESS paper. Sometimes it's difficult to find scapular artery. The most is from cervical trunk, almost 50%. And next is from subclavian artery directly, and 18%. Okay, sometimes from internal thoracic artery, this is 7%. Okay, next, in the case of knee, 8 vessel is important, like this. And among them, number 2, descending genicular artery, number 6, inferior medial genicular artery, number 7, inferior artery genicular artery are more important, more important, I guess. So because vascular bed is bigger, yes. And the previous study showed the category classification of genicular artery. Sometimes it's hard to identify for IMGA and ILGA. This one and this one. So according to this study, most IMGA derived nearby joint line nearby, and ILGA derived mostly below the joint line, below. And MGA feeds popliteal regions. There are 6 types of MGA according to this paper. And furthermore, descending genicular artery feeds medial regions. Is a very important vessels. And it has saphenous branch and articular branch. Mostly saphenous branch and articular branch derived from same trunk, maybe 97%. Sometimes only 5% derived independently. So, how do you determine which pathway is better, do you think? Here in Japan, implant plasticity frequently used. As I said, it's a temporary embolic material. Embolic effect is 10 to 20 minutes. However, in United States, embolism or embosphere are used frequently. This is a permanent embolic material. According to the United States paper, some minor complications like nerve palsy were reported. So I think permanent microsphere increases the risk of non-target embolization, I guess. So I guess maybe imipenem is better rather than permanent embolic material. So what kind of practice does Indian procedure? So I really interested in that. Next, so how do you determine appropriate endpoint? Intensive impairment stress in sodium and or embosphere only decrease abnormal nerve vessel or arterial venous shunt by angiography. So the important thing is elimination is not the goal. Elimination is maybe strong, maybe strong. So strong embolization can induce transient strong postoperative pain, especially small joint like elbow, wrist, Achilles tendon, something like that. It's point. So elimination is not so goal. It's not goal. So what kind of disease or what kind of finding for appropriate indications? There are various indication disease, frozen shoulder, osteoarthritis, lateral epicondylitis, plantar fasciitis. There are a lot of disease, and we think there are cases, what they are finding for a response to MSK embolization. For example, diabetes, thyroid dysfunction, rheumatoid arthritis, or nociceptor pain is more effective rather than neurogenic pain, of course, or bone marrow lesions, or old age. So these findings is poor response to MSK embolization in our experience. And finding regarding GAE, according to previous paper, fluorescent cartilage defect, cerebral meniscus injury, large bone marrow regions, over 20 millimeters, and grade 2-3 effusion synovitis is poor response to GAE. So if you can if the patient have this finding, so you have better alternative way to treat it. Next, I'll show you some result of papers. At first, frozen shoulders. My previous boss, Okino, showed the result of frozen shoulder for the first time. After 6 months, a mean visual analog scale was changed 82 to 8, and also improved functionally. And from Spain, also bus scores improved 8 to 0.05, and also function is also changed, and there are no major adverse events. Both studies use implant stress-testing as embolic material. So, next, regarding knee osteoarthritis, there are two famous studies. First, Dr. Ritter from United Kingdom, Genesis study. Fast and functional scores improved significantly. Bus was changed 60 to 36 points. And from United States, first RCT was published last year. Compared to sham group, Bus and Womack, both of them significantly improved. This is very important data, I think. So it's the first RCT. Besides, I published data of non-specific low back pain. So this is my paper. This study is so small number, unfortunately, but first report of the TAE for non-specific low back pain. So pain score and functional score is also significantly improved. However, so it's very important. So do not embolize spinal artery. Spinal artery sometimes visualize, so take care. Yeah. So what is the complications? Regarding complications, hematoma, non-target embolization, allergy, sensory palsy, skin discoloration over the embolized territory. For example, during treatment of plantar fasciitis, so discoloration was occurred like this. This is osteoarthritis and Achilles tendinitis. However, this is temporary findings. Okay, finally, I'll show you example case. Case is a 62-year-old female. She suffered from right knee osteoarthritis and pain duration is 3 years. MRI findings show at the medial component cartilaginous defect, meniscal protrusions, and osteophytes, like this. And no effect of conservative treatment like physical therapy and hyaluronic acid. In ultrasound, synovial thickening and some Doppler signals and meniscal protrusions are identified like this. In contrast, this is normal knee ultrasound findings. No synovial thickening, no Doppler signals, and no meniscal protrusions. Okay. So in angiography, this is the inferior medial genicular artery. With a treatment, stain at medial synovium identified like this. Again, like this. After treatment, it's really good clinical course. Okay, in conclusion, embolization for MSK is a possible treatment option for various pain. And permanent microsphere, of course, in my opinion, permanent microsphere increases the risk of non-target embolization. And especially GA, GA for knee OA is spreading rapidly around the world, like Japan, of course, Japan, United States, United Kingdom, New Zealand, Korea, Australia, French, of course, your country, India, Singapore, something like that. So I think GA has huge global market potential. So a lot of potential, I think GA has. So thank you so much. Thank you for your attention. Thank you so much.
So thank you, Dr. Keshi, for accepting our invitation and deliver this fantastic talk. And we are also using the imipenem over here in India. And sometimes when the cases are not responding with the imipenem, then we try to use the higher size embosphere, 100. Yeah. So when the patients are not responding, and most of these patients which are not responding, it's more uncontrolled diabetes, rheumatic arthritis, and gradually the important thing for MSK embolization is that you have to differentiate the osteogenic pain and the inflammatory pain, and we have to understand the pattern of the pain, and that is very important key for prognosis. Because if we treat the osteogenic pain, like you have shown the bone marrow edema pain, right, the patient is having the osteogenic pain, and if we treat such kind of patient, then the pain of the patient will not disappear, and ultimately it's a failure of the treatment. So we try to find out more and more inflammatory pain, and definitely genicular artery embolization is really promising treatment for knee joint pain, and it is helping lots of patients, and we are saving more and more knee joint from knee replacement. And in many other joints, like if you are talking about the plantar fasciitis, or if we are talking about the Achilles tendinopathy, there is no good surgical options available, and patients are suffering from pain since for a long times of their life. And if you offer such kind of MSK joint pain embolization treatment, then it works wonderfully in all these cases. Yeah. So thank you so much, Dr. Keshi, for accepting our invitation, and yeah, and we would continue the conference with other faculties. Thank you so much, Keshi.
Thank you so much.
Yeah.
Thank you.
Yeah. Bye.
Okay. So, can I exit?
Yeah.
Okay. Thank you.
Yeah.
Bye.
Bye.
બંધ થઈ ગયું છે એ પીપીટીસ કરું છું કઈ લેવાની છે એમાં ફર્સ્ટ સેકન્ડ બંને લેવાની છે કેનમાં નાખવાની છે 8 ફર્સ્ટ ને લાસ્ટ 1 yeah બે મિનિટ ઇધર લઈ લીધી છે આ 1 વાર લઈ લીધી છે મેં
It was indeed our privilege to have Dr. Fujiwara and sparing his time for us. Our next speaker is Dr. Bhavesh Vasani. He is a consultant radiologist with more than 25 years of experience in field of radiology. He has his own diagnostic centers in Bhopal and is also associated with various hospitals. He has developed a new social network for the doctors and entrepreneurs, MediConnect, which is excellent one-stop solution platform and is aiming to make it the largest virtual medical community. I would like to invite him on the dais.
Good morning, friends. Good morning, friends. Thank you. Okay, like this. Okay, that's fine. Good morning, friends. Thank you, Dr. Mohal and Dr. Rosil, for inviting me for this presentation. This is magical formula. Is truly a good learning perspective, good learning for our all perspectives. So, as you know, any entrepreneur journey starts with finding a problem. and at the same time they try to solve the problem. So recently one of our friends, they started one ICU with a huge investment of 1.3 crore. And as every business is risky, this medical profession is so. Eventually, in a short matter of time, they had to shut down the ICU and they tried to find a buyer. But hardly they could find any buyers in such a short time. And after investing 1.3 crore, hardly they recovered 30 lakhs. So this is the pain of any medical professionals. So though it is a very sad fact for everyone. So, but this became an inspiration for me to help medical community. So that's why we founded this MediConnect. Connecting the medical community and let them find the solution in a best way. So what is MediConnect? It is very unique platform to help medical professionals, which allows them to buy, sell any instrument. One can buy and sell any instrument from any medical doctors to any medical professional, even dealers. So it is very good one-stop solution for this all medical professional. Suppose some doctor wants to upgrade the instruments, or some doctor wants to go for newer modality of instrument, or where he will find the buyer, because buyer or any medical professional, because any buyer, it is not easy to find. So sometimes what happens, some third person comes in and they tells, okay, you can get this price, and it is very low price. So what MediConnect provides? It provides any another buyer, and by this platform across the India, right from the ECG, X-ray to MRI or cath lab or endoscope. So one can find any buyers. Now you can see here one doctor wants to sell the practice, ultrasound, and at the same time one doctor wants to start a new radiology practice. So it is very easy from them to get connected, and that they can buy this ultrasound machine from this MediConnect platform. So same time, here you can see the demo of our app. So someone has someone has put their machines to sell. So it is very easy. It is very easy interface for them. At the same time, in medical industry, we need to maintain machines, and it is not easy to maintain machine and find a relative service engineer for any instruments. So this our MediConnect, it helps them to find suitable engineers and suitable dealers. So now it is very easy to find dealers and engineers to maintain and repair machines. Even we doctors are very focused in our day-to-day work, and we cannot find new machines of various companies or new products, and we have to search a lot. So what MediConnect provides? It provides every machines, every company information, every machines technical information on one state platform. This is here, and dealer at the same time, dealer can post their products on this MediConnect. So they can showcase this medical product to entire medical community. So dear friends, doctors are the greatest source of patients, referring source of patients to doctors. So what MediConnect creates one community. So here it helps them to share news, achievements. It is just like Facebook and Instagram for medical community. With the help of this MediConnect, one can find buyers, one can sell hospital, one can even find another partners by this way, by this platform. Here you can see the real screenshot of our application, where one doctor has posted their advertisement for medical officers, and another doctor he has just started some hospital elsewhere in the city, and he is looking for someone who can join their practice, or who can join in a different way or sell the practice. So the MediConnect is the community which is all here. It is truly verified community. We verify every doctors, and then once they get verified, then they can share their post or reviews. So here you can see the all verified community platform. And in phase 2, we are just starting for jobs for doctors, technician, nursing staff, whether it may be full time, part time. So it and also a job portal for the surgical procedures. Like one surgeon wants to do surgery at other place, so he can share his skills to somewhere else. So it is helping the medical community a great. Even MBBS student can find their observership at some hospitals. So these are our next phase plans. So in a true way, MediConnect focuses on every need of medical community and truly connects medical professionals. So our app is currently available on Play Store. Thank you.
Thank you, Dr. Bhavesh. It was wonderful to have you here. I would like to invite Dr. Abhilasha along with Pooja to felicitate him. Moving further, our next speaker is Dr. Jitendra Patel. He is a consultant obstetrician and gynecologist at Priya Hospital and IVF Center. He is also specialized in laparoscopy and IVF. He firmly believes that for doctors, nowadays only a degree is not sufficient and one has to think beyond it. I would like to invite him on the dais.
Good morning to all of you. First of all, I would like to thank Dr. Mohal Banker for giving me an opportunity to talk on a subject which is close to my heart. Without taking much time, we are starting our talk. For doctors, only degree is not important. One has to be entrepreneur. Why? Because doctors are natural entrepreneur somewhat because of their profession only. Entrepreneurship is all about helping others and society at a large. As a healthcare provider, it is easy for them to do so. Following are the few reasons why doctor has to become an entrepreneur and mere degree is not important. First is the quality. Following are the qualities. First is tenacity, that is the determination, grip and persistence. Second is commitment to continuous professional development and learning, passion for the discovery, research, testing and experimenting, desire to make a difference, interpersonal skills, pattern recognition and dealing with uncertainty. Because of the following reasons, doctors hesitate to become an entrepreneur. There is a fear of failure. Can I do it? Will it work for me? What if I fail? And there is no professional guidance or hand-holding in this domain. And so the lack of community support is also. So what is the solution of three blocks which are faced mainly by doctors or any other healthcare professionals when it comes to a healthcare entrepreneurship? The first block which commonly facing by all is there is a fear of failure. Can I do it or will it work for me? And what if I fail? So fear of failure. Because living our comfort zone, monotonous life versus adventurous life, lack of clarity due to unclear roadmap and handholding, fear of losing as well as competition and fear of a non-competitive environment like toppers ego and then the want to become perfectionist, and finances and family responsibilities are always there. So why there is a fear of failure? Because there is no definitive goal setting or a plan for the future when we pass out from the medical college. For example, when we were studying in colleges, during those years there was a definite deadline and goal for the exams, studies and structure of course is already planned. So we know about what to do, but when we go out in the market or doing a job and seeking for the independence, then there is no definitive framework to follow. So we have to pay the cost of freedom. how to treat and manage patients was taught in the medical colleges, but to set up a private practice, there is no definitive course in colleges. So, jitna kathin sangharsh, utni hi shandar jeet. The second block, which is mainly faced, is there is no professional guidance or hand-holding in this domain. So we don't know anything about the private practice, so we go to the find out ways and means like online platforms, websites, seminar, colleagues and seniors. During the last few years only, we have a professional guidance is available online, but before that we have to rely upon our colleagues and seniors, which was not enough for the confidence build up. Which is the third block, lack of community support. In a country that doesn't have even one doctor for every 1,000 population, it is very difficult to fail. You will have to work hard not to fail. In India, we don't celebrate failures. We can't even accept failures. People are so judgmental. People will not spare any effort to put a germ of doubt in your mind. If you are struggling, they will tell you never have it in you. But once you are successful, the very same people will say, I always knew that you will become a big man or woman someday. So even in the family, it also prevails that this mindset is there when our parents think that the child should be safe and secure. Most of the time, our parents also done a job in the past, so they were not having experience of any kind of business or entrepreneurship. So for them, safety and security of government job is first. But nowadays, scenario has been changed. Why? Because more and more doctor families or doctorpreneur families, kids are coming in the field. So 20 to 30% doctors are most of the time from the private practitioners, doctors family. But for them, biggest challenge is to carry forward the legacy like their doctor parents. And even sometimes they will add to your self-disbelief, but they will change the tone once you are successful. So this is the world where we are living in, and this is the reality. So now we coming on the part, there are lots of opportunity in India. Healthcare in India from $150 billion in 2020 to $372 billion by 2025, expected more than double in next years. Government expenditure on rising trend like Pradhan Mantri Jan Arogya Yojana and Ma Card, etc. Digital health will be the norm. Increasing foreign funding, consumer changing behavior from value conscious to the digitally enabled. So where is the gap? 75% population with no health insurance till today, 2 million gap in the bed capacity, 3 trillion cumulative healthcare spending request by 2025 already raised, and 1.3% of our GDP right now we are spending on a healthcare. But in a developed countries like European nations and US, they spend almost 8%. So why now? Because our economy is rising trend and rising income level, higher disposal of income. In a post-COVID world, greater focus on health by both government and individual also. So increased lifestyle diseases like cancer, diabetes, heart disease, improve access to insurance, and also accelerated by digital economy, support and acceptance of entrepreneurship during this era. That's why best time to start there are very few entry barriers. So doctor as an entrepreneur, who can become and why, and then why the fear and what are the common myths? So who can become an entrepreneur? First is a skill, medical education. Specific skills like laparoscopy or as like Dr. Mohal Banker, this genicular artery embolization, specific fellowships and experience, and also the business knowledge. And second is the risk-taking capability. It came from the family environment, peer group mentality, and as you know, in Gujarat, we Gujarati people already having the risk-taking abilities more than other. So calculated risk professionally we have to take. So what is the purpose? Our purpose must be larger than, and in the larger society, larger interest of the society to provide a proper health care to everyone. So why? For himself, herself, money, fame, satisfaction of the work, growth, for their family, they spend a quality time and more resources, society at a larger interest, ultimately contributing to the nation. So then why the fear? Already we know because of our education system, which is long and costly, promotes less risk-taking approach, Hippocrates oath, all about ethics, comfort zone, fixed monthly salary, professional cushion, monotonous life, And lack of clarity, already we have seen no clear roadmap or handholding. We also seen like a fear of losing competitive environment and finances. So which are the common myths? It is very risky to start a private practice. Lot of statutory hassles, like various licenses of fire NOC and BU permission and all that. Lot of money is required. Without big context, nothing can be done. I can't handle the digital media marketing. What if patient does not come to me? So this is my dream hospital, and everybody can dream on their own. So which are the 5 essential parts of business? This is most important, because value creation and value delivering, then marketing, and then sales, and also finance and accounts. So what is value? Discovering what people need or want, then create it. So what is value delivering? Hospital itself synonym with service and care. The word hospitality came from the hospitium, stands both for hospital as well as hotel. As per WHO, hospital is defined as an institution which provides complete health care, both curative and preventive, including home care, and also providing training to the healthcare professionals. So giving your customer what you have promised and ensuring that they are satisfied. Rating, marketing, attracting attention and building demand for what you have created. As per the current scenario, social media is the best platform for marketing. Sales, turning prospective customers into paying customer. As you know and aware, medical representative comes to you and promote their products. So finance and accounts, bringing in enough money to keep going the show and making your efforts worthwhile. So fundraising, from where? Initially, we have to borrow from the friends and family, bank loans, NBFC, different funds, and also MSME schemes are also available right now. Private equity and special incentives for women, and also this for special category. Few concepts of business you have to understood. That is ROI. What is when it starts? ROI is return on investment. Direct expenses will be 30-40%. Like on the hospital running cost and equipments and etc. Maintenance of equipments and monthly expenses like staff salary and various bills 20-30%, and 30-40% should be gross profit. So for ROI calculation, you have to keep in mind about the expenses. Proportion of investment, 40% investment should be on a non-productive assets like building, furniture and fixed assets, and 60% on the medical equipments, beds and machineries, etc. So what is the valuation of hospital? Valuation is different in all businesses, but grossly or largely depends upon location, balance sheets, career period, etc. or experience. Valuation importance because few corporates are coming up with LLP. If you have a ready-made high value hospital or business already running where we can do the partnership and take advantage of marketing and management of opposite party. Valuation is about 20 times of a gross profit or a fixed asset, whichever is lower. So keeping that in mind, you have to put everything on paper. And marketing budget, as you know, 1-2%. Maximum cost should be less than or equal to 4-5%. Depreciation, you have to keep all the income on paper, so we'll get the maximum benefit of depreciation, and thereby we are reducing the income tax. So these are the different 12 forms of value. Thank you very much for patient hearing.
Thank you, Dr. Jitendra. It was quite an inspirational talk. Now I would like to invite Dr. Nisarg Thakkar and Mr. Shambhu to felicitate Dr. Jitendra Patel.
खोलो
नहीं ये होगा
मैडम का इसमें मैडम
हाँ
ये पूछ लो खाली ये कान
इट्स फाइन
मैडम का इसमें लास्ट
ટેનમાં નીચે પેસ્ટ એમાં નથી કરવાનું બેક ક્લોઝ અહીંયા પેસ્ટ કરી દો नहीं हिल पेन में जाओ हिल पेन सेक्शन 9 में जाओ Moving forward, we have another speaker, Dr. Drushi Patel, who would be speaking on behalf of Dr. Gaurav Goswami. He is not able to join us due to unavoidable circumstances. Dr. Drushi Patel is consultant radiologist at Gujarat Imaging and Samved Hospital. She also has a keen interest in musculoskeletal radiology. I would like to invite her on the dais.
Thank you for the kind invitation and thank you for having me. I would like to thank Dr. Mohal sir and Rosil for having me here. This is an impromptu lecture and I'm filling in for Gaurav, who couldn't be here right now. I'm going to talk on imaging of plantar fascia. So plantar fasciitis is a low-grade inflammatory process involving the plantar fascia, wherein it can be de novo or it can be due to an underlying systemic disease, and in adults it may be associated with pes planus or cavus. Other features which are responsible for it are stress due to repetitive trauma or degenerative disease or associated systemic diseases. So the systemic diseases associated with plantar fasciitis are seronegative spondyloarthropathy, like ankylosing spondylitis, reactive and psoriatic arthritis. Typically, the patient presents with heel pain first thing in the morning as they put their foot down, or after prolonged sitting, and when they try to weight bear, there is severe heel pain. The imaging modalities for its evaluation are ultrasound and MR. Plain radiographs are obviously non-specific. There are no findings on plain MR, but the foot abnormalities like pes planus can be identified on the radiograph, and sometimes there might be a speck of calcification at its attachment at the calcaneum, which can be appreciated on a radiograph, or there may be an inferior calcaneal spur that can be identified. On ultrasound, the plantar fascia is seen as a linear band which is hyperechoic, and you have to trace it from the calcaneal attachment, and it is if it is more than 4.5 millimeters, it's considered to be thickened, but more importantly, comparing it with the contralateral side, if it is asymptomatic, is better. MR, on MR we can identify the edematous changes in the plantar fascia, as well as some marrow edema that may be associated with in the calcaneum at the site of its attachment, or there may be inferior calcaneal spur that can be identified on MR. So these are the ultrasound images. The first one is the short axis image of the plantar fascia. This is an asymptomatic side and this is the symptomatic side, where you can see that the fascia is thickened compared to the normal side. This is the long axis view, where you compare it with the normal side, it is thickened and hypoechoic. The same thing, this is at the calcaneal attachment. At the insertion, this is the asymptomatic side and this is the symptomatic side. Here you can appreciate that there are hyperechoic and linear appearance, whereas it is hypoechoic or dark areas suggesting edematous changes at this side, and also there is thickening of the fascia at its insertion. When you put a Doppler, you will see that there is vascularity around it. On an MR, the typical appearance is thickening of the plantar fascia, and there is this bright area is the edematous changes, and this is the edematous changes at its attachment in the calcaneum. The T2 weighted images are good to identify these, whereas on the T1 weighted images you can appreciate the spur better, inferior calcaneal spur at the site of attachment of plantar fascia. this is an example of one of the complications that can occur, wherein here it is engulfed by an abscess and there are other inflammatory changes in the Kager's fat pad. This is not per se plantar fasciitis, this is rather a complication, an abscess. So the take-home message is that you need to understand the anatomy and the imaging modalities for evaluation of plantar fasciitis. There is a difference between normal and abnormal, and when you compare it with the contralateral side, especially on ultrasound, helps. And you can follow up after an intervention or physical therapy or intervention related to how the response is on ultrasound. Thank you.
Thank you, Drushi, for a wonderful talk, and you have covered lots of points and make us a clear understanding of this topic. So now our next speaker is Dr. Isha Trivedi, and she has done her masters in cardiovascular and pulmonary physiotherapy from VS and SPP Hospital, and this is a very unique combination of physiotherapy and psychology, and she has also done a clinical psychology and nutritionist. At a very young age, she aspired to become a holistic healthcare profession and make advancement. I would like to invite her, Dr. Isha as a speaker to come here and present in front of all you.
Good morning, everyone. So, what is plantar fasciitis? Plantar fasciitis is a common musculoskeletal disorder which is characterized by pain involving the inframedial aspect of the heel. It increases on the weight bearing. There are three changes basically seen, that are degenerative changes, fibroblastic changes, followed by chronic inflammatory changes. Now, what are the clinical features? As you can see, there is pain over the ball of the heel, tenderness on the plantar aspect, slight swelling may be present or may not be present, and painful first few steps, especially in the morning. Now, what is the pain pattern? So, during first 15% of the gait cycle, passive structures of the foot, that is bones and the ligaments stabilizing the ankle joint, take more than 120% of the load. Maximum stress is on the plantar fascia in order to stabilize the foot in the phase of the heel raised to toe off. So the repeated stress is placed on plantar fascia and it leads to plantar fasciitis. Pain is relieved as soon as the weight bearing is discontinued. So now what are the treatment options? Well, a physiotherapist may have treatment solutions. Rehabilitation and physiotherapy approach for plantar fasciitis. So now how to relieve stress? So the first basic aspect is relieving stress on the plantar fascia. So take first few steps on toes in initial weight bearing. When you wake up in the morning, take your initial weight bearing on the toes. The second one is UCBL shoe inserts. These are the orthoses which can be provided to the patients. An elongated soft heel pad or well padded medial arc can be given to the patient. Now the strengthening of the intrinsic foot muscles. So in morning, immersion of foot in hot water and toe curling can be done for the several times. It recruits the intrinsic muscles. Sustained toe curling with a hold and thorough practices throughout the day. So more repetition, more strengthening. And Faradic stimulation of foot, it is one of the modalities which a physiotherapist give to the patient. So the first one is placing in hot bath, intrinsic foot muscle exercises, toe curling exercises, and the third one is Faradic stimulation. Now maintenance of the longitudinal arc of the foot, so proper shoe inserts are required and walking on outer border of the foot, as you can see in the image. Other exercises are straight leg raising exercises. We call it as SLR. So it helps in regaining the strength and endurance of the lower limb muscles. Initially, without touching the without heel touching the bed, progress and hold and add resistance as per the capacity. As you can see, we have to do these exercises in supine lying position. Relaxation and manual release of the plantar fascia. So these are the exercises which can be given to the patient, and in that patient can perform actively. So the first is frozen cane roll. We can give it to the patient. A bottle can be given to the patient, and the patient is told to follow the instruction. The second one is towel stretch. We can use TheraBands also. The third one is standing calf stretch. Fourth one is seated plantar fascia stretch, which helps in the release of the plantar fascia as well. Plantar fascia massage can be given, and Achilles tendon stretch can be given to the patient. So these are the commonly incorporated plantar fasciitis exercises, that is towel stretch, as we heard, standing calf stretch, plantar fascia stretch, static and dynamic balance exercises, because in plantar fasciitis balance is affected due to the inflammation. Towel picking up, that we can consider is a toe curling exercises. Frozen cane roll, resisted dorsiflexion can be given to the patient, resisted plantar flexion, inversion and eversion activities. Taping can be given to the patient. The steps are given accordingly. Now, what is the take home message? Plantar fasciitis accounts for an estimated 11 to 15% of all foot complaints requiring professional care in adults. Studies have shown that 90 to 95% cases of plantar fasciitis resolve within 12 to 18 months of conservative management. Hence, timely taken rehabilitation and physiotherapy treatment in plantar fasciitis can be much more helpful and effective. Thank you.
Thank you, Dr. Isha, for wonderful presentation. And then I would like to invite Dr. Abhilasha Thakkar for her next talk. And Abhilasha is a gem of our hospital, Bankers Vascular Center, and she has a very thorough knowledge about.
Once again, hello all. We'll see heel pain embolization. Heel pain is a very good wide disease, and heel pain causes are mainly plantar fasciitis, as Dr. Isha told, Baxter's nerve compression, some of the high heel arch, calcaneal stress fracture, injury to your heel, many more, but most common is plantar fasciitis. All things Dr. Isha has explained very well, but some kind of idea we will mug up. Plantar fascia, you can see structure, thick band from heel bone to your toes. Now you'll get inflammation in this band. Plantar fasciitis, overuse of plantar fascia, mainly you'll get overuse. So what are the reasons behind it? Foot mechanics, flat foot or high arched foot, prolonged standing. Some professionals are having prolonged standing. Body weight. You will alter your weight after some things, so you'll get plantar fasciitis. Athletic persons, running, jumping are the higher activities for them. Calf muscle of tightness of calf muscle, you'll get in some postures. Changes of footwear, you'll get your footwear changed, sometimes you'll get heel pain due to that. Change in activity. If you are starting your exercises, daily exercises, in between you have stopped your exercises and again you start your exercises or other kind of exercises, changes in your activity can cause heel pain. Hallmark symptom. What will be the hallmark symptom of your heel pain? Morning first step will be like hell. Morning first step which reduce after few steps, but first step will be very painful. And first step after prolonged sitting. If you are sitting for 30 minutes or more than 35 minutes and then you step up, when you put your first step, it will be more painful. Many treatments are there, as Dr. Isha suggested. Conservative management, physiotherapy works in 90%. Again, 10% are not recovering, so we are there for embolization. But what if we do? Steroid injection is a bad choice. Many of patients are using this nowadays, but it will damage your bones. So yes, we have solution. Heel pain embolization is a good choice for your long-lasting heel pain reduction. Heel pain embolization, what we do exactly, we target the cause. We target on reducing inflammation and its effect. Angiography will be done of your plantar artery. We will identify your moya blood vessels and embolize it. It reduces inflammation and pain. Now we'll see our cases. Recently we have done one case of rheumatoid arthritis, severe heel pain. As I told, morning first step pain, very severe. Many times night pain was present. Now this is the video. See, this is the video of during procedure, pre-embolization and post-embolization. You can see a flush. Inflammation you can see over here. These dark patches are inflammation site. In this, we are resolving it. Results post-procedure, patient pain reduced 90% and now able to sleep properly. No disturbance in night sleep. Next case, severe pain in right heel started after wearing high heels. This patient has changed her footwear. Marathon run, not able to walk properly, taken steroids also. No recovery. Treated with heel pain embolization at our Bankers Vascular Center, 80% pain free. Case 3, suffering from heel pain since 10 years. When Rekhaben came to my OPD at Baroda, she has come with many files, with many doctors. She has gone with many treatments. She has done homeopathic, Ayurvedic, everything, home remedies. Apart from money, she was not able to enjoy her life due to heel pain, right? We did heel pain embolization, severe inflammation, plantar fascia attachment. After embolization, all inflammation got disappeared. Pre-procedure and post-procedure images over here of Rekha Ben. And now she used to call many times that you did a magic and you gave me a pain-free life after 10 years. We'll see Rekha Ben's.
I'm Dr. Dimple Verma. આજે આપણે એક એક્સપિરિયન્સ શેર કરીશું. અમે એક પ્રોસિજર કરી છે heel pain embolization. તો એ પેશન્ટ જોડે આપણે પેશન્ટને કેવું રહ્યું એનો એક્સપિરિયન્સ એ આપણે શેર કરીશું આજે. હેલો મેડમ. તો તમને પ્રોસિજર પહેલા શું પ્રોબ્લેમ થઈ હતી એ તમે શેર કરશો અમારી સાથે?
મને 10 વર્ષથી પેઢીમાં દુખાવો હતો. 10 વર્ષમાં જેટલી ટ્રીટમેન્ટ કરવાની હતી, લેઝર છે, અલ્ટ્રાસાઉન્ડ છે, ફિઝિયો કર્યા, બધી અલગ અલગ ટાઈપની ચપ્પલો, જે કોઈ કે એ બધું કર્યું, પણ મને જરા પણ ફેર ન હતો. મેં એક દિવસ આ વાંચ્યું, યુટ્યુબ પર જોયું. મને લાગ્યું કે ઓપરેશન વગર છે તો મારે કરાવવું જોઈએ. મને વિશ્વાસ લાગ્યો તો મેં આ ઓપરેશન કરાવ્યું. મને બહુ સારો ફાયદો થયો. મને 10 વર્ષનો જે દુખાવો હતો એના જેવો મટી જ ગયો છે અને ચાલવામાં કોઈ તકલીફ નથી પડતી.
ઓકે, તો હવે તમને એ પ્રોસિજર કેવી લાગી?
પ્રોસિજર બહુ ઈઝી લાગી. એ અડધા કલાકમાં ઓપરેશન થઈ ગયું. પંચર કર્યું ને એમાંથી દવા રાખીને કર્યું તો સારું લાગ્યું. એનેસ્થેસિયા આપ્યું પણ જલ્દી તરત જ થઈ ગયું ને થઈ ગયો. પછી પણ 2 કલાક 4 કલાકની રજા આપી એટલે પછી પણ ફિઝિયો કરો કે આ કઈ ટ્રીટમેન્ટ નહીં થાય, રેગ્યુલર ચાલતા બોલતા રહીએ.
હવે તમે જે આ પ્રોસિજર કરી એનાથી તમને કેટલો બેનિફિટ રહ્યો? એ પ્રોસિજરથી તમે તમારી ડેલી એક્ટિવિટીઝ કેવી રહી શેર કરશો?
ડેલી એક્ટિવિટીઝમાં બહુ જ ફાયદો થયો. જે પેલા હું બેસી ગઈ હતી કે ચાલવાનું જતી નહોતી, એ બધું થોડું ચાલવાનું ચાલુ થઈ ગયું. રેગ્યુલર રૂટીન કામમાં પણ પગ જે દુખતા હતા ઉભા રહેતા એ બધું મારું.
So, Rekhaben was so happy and a conclusion is non-invasive. This treatment is effective method for plantar fasciitis. No major complications, no cut, no scars, no dressing. Long lasting and faster results more than larger joints and a lesser chance of reoccurrence. So, whenever you get heel pain that is not resolving, that is not treated, that is not cured, please do come to Bankers Vascular Center. Thank you.
Thank you, Dr. Abhilasha. Moving further, I would like to invite Dr. Drushi Patel. Dr. Drushi has keen interest in musculoskeletal imaging. She also has keen interest in prostate as well as brachial plexus imaging. She is one of the chief consultants at Gujarat Imaging and Samved Hospital. I would like to invite her on the dais.
Thank you for having me here. Now I'm going to talk on imaging modalities for evaluation of tennis elbow. So tennis elbow is an overuse syndrome wherein which involves the common extensor tendon, predominantly the ECRB. Patient typically presents with a lateral elbow pain. There is tenderness and swelling. And this is increased when they grasp objects during wrist extension with resistance, like in racket sports or repetitive activities that occurs with certain occupations like painters. So the anatomy at the lateral elbow is there is a common extensor tendon origin, and below that there are the lateral collateral ligament complex insertion. The common extensor tendons are that originate at the lateral epicondyle. There is the extensor carpi radialis longus, which is above the common extensor tendon origin. The first tendon here is the ECRB, and then there is the extensor digitorum, and lastly it's the ECU. Beneath that there is the ligament complex, which provides stability to the lateral elbow joint. So whenever there is repetitive stress and overuse, there is common extensor tendinosis. Tendinosis meaning there is inflammation or edematous changes at the common extensor tendon. Later on, eventually there will be micro tearing and progressive degeneration due to immature reparative response, which will eventually result into full thickness tendon tear. So these are the continuum of findings that we see on the imaging modalities. So the primary role of imaging, it's a clinical diagnosis. The role of imaging is to exclude other causes of lateral elbow pain or underlying ligamentous injury, if any, especially in patients in whom the conservative treatment has failed. Radiographs therefore would be helpful to exclude the other pathologies. USG has its advantage of providing a dynamic evaluation, and there is scope for interventions, and MR is the gold standard. A typical radiograph, usually it is normal, but sometimes there may be a small calcific speck adjacent to the lateral epicondyle within the common extensor tendon. This is because of the calcific tendinopathy or enthesopathy, which can be seen in 25% of the patients of lateral epicondylitis or tennis elbow. Ultrasound is a very good investigation for evaluation of lateral epicondylitis, and where longitudinal plane evaluation is done, and we can see that this is a typical image showing the common extensor tendon. This is the lateral epicondyle and its slope. This hyperechoic structure is the common extensor tendon. This is the radiocapitellar joint, and this is the radial head. So this is the site that we are evaluating whenever we are doing an ultrasound for evaluating the edematous changes. Findings in tennis elbow involves involves having edematous changes or hypoechoic changes in the common extensor tendons, and when a Doppler is placed there will be increased vascularity at this site. These are typical features of common extensor tendinosis. On MR, the structures are better visualized right from the outside the common extensor tendon to the ligament complex underneath and the bones. So this is how on MR these things look like. So this is a typical common extensor tendon origin, wherein the anterior tendon is the extensor carpi radialis brevis, which is the first to tear, and then there is the digitorum. The underneath is the ligament complex, that is the radial collateral ligament, which the posterior component is the lateral ulnar collateral ligament that inserts into the ulna, and these are the extensor tendons and their myotendinous junction. This is a typical coronal image which helps identify common extensor tendinosis, wherein this is the common extensor tendon and underlying ligament on coronal images. So initially when the patient has lateral elbow pain due to lateral epicondylitis, they will have only subtle edematous changes involving the common extensor tendon, and this is tendinosis. The ligaments are normal. There is an MR classification to identify the continuum of findings from tendinosis towards partial thickness tear towards full thickness tear, and that can be identified on MRI. This is in another case wherein the 66-year-old female. Now you can see that here there are fluid intensity signal at the common extensor tendon, and that represents a tear. These are the coronal MR images showing greater than 50% thickness of the common extensor tendon tear, and with the intact underlying ligaments, though they are showing some amount of thickening and edematous changes due to the stress. Another case of tennis elbow where there is changes of tear within the common extensor tendon, which you can appreciate on all the planes. Besides that, on T1 weighted image it had some dark area inside which represented calcification that suggests a chronic process. And lastly, this was a 68-year-old female with elbow pain. She had past history of steroid injections. Here there is a full thickness tear. You can identify that there are no structures in this region. It's the ligament as well as the common extensor tendon that is torn. And the role of imaging is to identify and exclude the other differential diagnosis, like presence of a radial head fracture, which will also present as a lateral elbow pain, but there is history of trauma, and X-rays and other modalities are helpful to identify this. When there is history of trauma, presence of instability, it can be due to the underlying ligament tear with the common extensor tendon being intact. Here there is the RCL tear. And as you can see that the retracted tendon end is here, and on CT there is an avulsion fragment, bone fragment that is retracted. This is another one with a chronic lateral elbow pain and history of trauma, where you can see that there is osteochondral lesion with edematous changes responsible for the pain. Of volleyballer with a lucent lesion at the epicondyle at the capitellum, and which was an unstable osteochondral lesion responsible for the lateral elbow pain. And lastly, radial tunnel syndrome, which can clinically mimic tennis elbow, but if you see the site of pain is different. The tennis elbow pain is at the lateral epicondyle, whereas this is a little more distally, and wherein the nerve, as it passes underneath the longitudinal septum beneath the supinator muscle, it will be entrapped and will cause the lateral pain, and wherein there will be denervation changes in the supinator muscle, which is supplied by that particular nerve. So that is radial tunnel syndrome. To summarize, it's important to know the anatomy to understand the continuum of findings that happen from tendinosis towards tear. The ultrasound and MR appearances of tendinosis and tear are different, where tendinosis is just thickening and tear is where there is a fluid gap which can be identified on the respective modalities, and the differential diagnosis for excluding other causes of lateral elbow pain. Thank you.
Thank you, Dr. Drushi, for such an informative session. I would like to invite Dr. Dimple along with Nisha Vyas to felicitate Dr. Drushi Patel. Right. Heading further, our next speaker is Dr. Mihirdev Jhala, who is the principal of JG College of Physiotherapy located at Ahmedabad. He is MPT Neuro Guide and also a PhD scholar. He has published various national and international papers. He has keen interest in research and also believes in approaching the patient practically. He is a great sport enthusiast, which also defines a add-on quality to a true physiotherapy professional. I would once again like to invite Dr. Mihirdev Jhala on the dais.
Good afternoon to one and all present here. First of all, I'd like to thank Dr. Mohal Bankar sir, Dr. Rosil Gandhi for the invitation. As Dr. Drushi has already said about the anatomy and the clinical features of the lateral epicondylitis, that's a tennis elbow, I'll not waste much of the time on that. Rather, I'll be starting then with the brief introduction of the condition and then a brief physiotherapy management. As you all know, it's a pathological condition of the common extensor muscles at their origin on the lateral humeral epicondyle. And it's tendinosis of extensor carpi radialis brevis, and sometimes also extensor carpi radialis longus is also involved in this condition. And the other terminology of tennis elbow is usually lateral epicondylitis 2. You can see the extensor origin there, it takes place, the inflammation and then tendinosis, and then later, as Dr. Drushi said, tear can also occur if not treated on time. So usual causes are repetitive stress injuries, that is overuse injuries, and the usual age we find this condition is in 35 to 55 years of age, and males and females both are usually equally affected in this condition. Depending on their occupation, the technicians, the mechanics are usually affected. The sports persons, especially the tennis players, are usually affected with this condition. As you all know, Sachin Tendulkar, a well-known cricketer, he also suffered from this condition, and it took a bit long for the recovery in tennis elbow. Symptoms usually diffuse pain on the lateral aspect of the elbow, morning stiffness, dropping of the objects because of the weakness in the grip, soreness of the forearm because the pain radiates usually from the lateral epicondyle region to the forearm also at many of the times, tenderness over the bone on the outer side of the elbow. On palpation there will be tenderness too. Now the main part, how to treat this condition, what is the physiotherapy management. So usually I have accumulated few techniques, those are usually practiced in the physiotherapy clinic. Those are manual techniques as well as some electro modalities are used to treat this condition. What are our goals? First of all, as a physiotherapist, to control the pain, to decrease the pain so that the patient can focus in his daily activities, his occupation, his work life easily. Second, encourage the healing process. It's must, because even with the exercises or the mobilization, manipulation we give, if proper rest is not given, then the healing process will not occur and ultimately the patient will go home with more pain. The third one, restoration of flexibility and strength, and the last one, gradual return to the activity and the work. To reduce pain, usually we prefer in the acute pain, usually tendinitis is there or any inflammation is there, we prefer giving the ice massage over the lateral epicondyle or condyle region over the extensor origin muscles. Electrotherapeutic modalities such as ultrasound, laser, high voltage galvanic stimulation are usually given. Ultrasound, it helps in repair also. The evidences say it helps in regeneration and repair process too. And laser and high voltage galvanic stimulation will reduce pain too. Heat retaining brace such as neoprene sleeve worn during the rehabilitation process will improve the healing process and repair process too, because it distributes the force during the exercises in a proper way, that not only the stress has been given to the extensor origin, but it redistributes the force among the soft tissues around the elbow. For the sports players, usually as seen in the picture, counter force bracing is given to reduce the forces on the extensor tendons. Transverse friction massage, that's a soft tissue therapy over tight or thickened tissues. In this position, as shown in the picture, could be given to the individual suffering from this condition. It will allow to decrease the adhesion formations, which is usually seen in the chronic phase. Sustained longitudinal pressure on the ECRB, extensor carpi radialis brevis muscle in the position that where the elbow is fully extended and the wrist is flexed. This is given as a part of the physiotherapy rehab program. The next one is digital ischemic pressure to deep muscles. Fibers in the shortened position is given, that is to brachioradialis, extensor carpi radialis ulnaris, extensor digitorum, extensor digiti minimi, ECRB as well as ECRL. In this shortened position, it is given usually. It's a deep digital ischemic pressure. It says it will reduce some inflammation and it will reduce the pain thereby. Stretching of the ECRB is of utmost importance in this condition, as ECRB is the most prone muscle to get affected in this condition. So this is how the position, the shoulder is in bit of scaption and abduction, and elbow is in full extension and wrist goes into flexion. This is how in the forearm is in pronated position. This is how ECRB is stretched, and it helps. A technique called a cervical neural stretch. It's nothing but it's just same thing as we do in neural tension tests. It is used as a rehabilitative procedure where it says that at a spinal level the pain decreases. There's a modulation of pain if we sensitize the nerve. So cervical neural stretch is important to reduce the pain at times. The taping technique, as you have seen many sports players doing the taping, the specific diamond taping method is used to decrease the pain in this condition. Even while playing the sports also, this kind of taping helps to an individual to decrease the damage and to decrease the discomfort during the sport. Now later on, once the pain subsides, when the recovery phase is going on, inflammation is decreased, thereby one can start the strengthening process also. So this is the ideal position where the shoulder is supported, elbow is supported, forearm is supported, and the wrist is outside. With the help of some weight or dumbbells, gradual strengthening could be started with wrist extension and flexion, so that the isometric we should start, then followed by eccentric and concentric contractions of the muscles will usually help to strengthen the extensors and flexors both. The two evidences I have generated in this condition from the database. One is Cyriax physiotherapy. Usually Cyriax has given a process called as Mills maneuver, which not only alone but with deep transverse friction massage could be of useful in this condition. The evidence shows that it helps in reducing pain and it helps in recovering from this condition. The second one is mobilization with movement, that is a Mulligan technique with exercise. The second one, corticosteroid injection only, and then the third approach was wait and watch for the tennis elbow. So the physiotherapy combining elbow manipulation and exercise has superior benefit to wait and see in first 6 weeks and to corticosteroid injections after 6 weeks. So ultimately physiotherapy with some exercises is useful in this condition along with medical management on time. Thank you so much.
thank you, Dr. Mihir Devjala, for such an informative session. I would like to invite Dr. Rosil Gandhi along with Hitesh to felicitate Dr. Mihir Devjala. Now here we are with the another useful session of another useful and last session of Dr. Mohal Bankar, who will guide us with magical formulas of how to treat elbow and wrist pain.
So this conference is planned in a such a way that each session is designed in a it's separated into three parts. One is imaging, how to imaging the joint. Then second part is how to treat it without any kind of invasive procedure, that is physical therapy. And our role comes when all this physical therapy fails. There are 90%, 80 to 90% we have seen that physical therapy works wonderfully, and within the time period is 2 to 3 months. If by taking the physical therapy for 3 months and if patient does not improve the pain, then we came into the picture. So these are tennis elbow and golfer's elbow. One is affecting the extensor group of the elbow, and second one is affecting the flexor group of elbow. And what if all this physical therapy fail? The guy is called Dr. Yuji Okuno. He is an intervention radiologist, and he has published the first paper on this transcatheter arterial embolization using the imipenem for this tennis elbow, and we learned from him. So our target is chronic inflammation. This therapy is useful to reduce the chronic inflammation. By reducing the inflammation, we are reducing the pain and further damage. And actually the name is tennis elbow is really misnomer. It does not affect the only tennis player, but actually more and more affected the normal homemaker, housewife. They are doing the repeated activities and they are affecting their elbow joint, and they come with the tennis elbow complaint. So like this patient, a homemaker, develop elbow pain since last 3 years, severe night pain, not able to do routine work like making chapati, lifting tumbler by doing taking bath, and we have done these tennis elbow embolization, and you can see over here these are pre-angiographic images, and these are extensor attachment over here. These are vascular blush. So these vascular blush is a moya blood vessels, which is a site of chronic inflammation. So once we identify this chronic inflammation site, we inject small embolizing particle. So main arteries remain intact, but these moya blood vessel will disappear by this procedure. And patient pain reduces by 70%. No night pain, sound sleep after the long time. The second, this patient has a 10-year-old trauma into elbow joint, developed fixed flexion deformity at elbow, developed pressure wounds at elbow, not healing since last 10 years. You are able to see in the X-ray also there is a very soft tissue swelling, and there is a small pit over here. There is ulcer of the patient and severe night pain. Taken so many antibiotic, other wound management treatment, but not responded. And these are fixed flexion deformity, and there is a wound over here. So what to do the next? Medical therapy, it was fail. He has spent lots of money for medical therapy. Tried surgical wound debridement, other wound management last 9 years. 9 to 10 years is very long duration. Most of the patient has tried all the things, all the duri, daga, or whatever the treatment available in our India. Everybody has tried, and this patient is really affording that he has tried everything. He has to take painkiller every day to reduce the pain, not able to sleep with the painkiller because of severity of pain is so much. Then everything was failed in last couple of years. Patient suffering from a lot, and somehow by God grace he find it out, and we have tried the MSK embolization to reduce the inflammation. Let's see what are the finding. So if you are able to see over here, these elbow joint and these are vascular blush over here. the severe vascular blush, early venous drainage, which suggestive chronic inflammation. And once we identify this chronic inflammation, and we started injecting the embolizing particle. So this is how it looks on the angiographic image. This is a vascular blush, this is a elbow joint over here, and the post embolization, these vascular blush disappear and the normal vessels are still intact. So this treatment works wonderfully. And these are pre-embolization images. All these vascular blush, which is in Japanese language, it's called moya blood vessels. Why it's a moya blood vessels? Moya means abnormal blood vessels, and these moya blood vessels are responsible for releasing the cytokines at the affected area, and these cytokines keep continuing chronic inflammation activity at the local site. And we are injecting the small particles which are exactly the size of these moya blood vessels, and by injecting it at the local site, we block these moya blood vessels, and the normal blood vessels, normal parent artery, are still intact. And by doing this, we stop the chronic inflammation at the local site. And let's have a results. Patient's pain started reducing, wound start healing within 2 months. Wound healed by 70%, patient's pain reduced by 70 to 80%. And when he came the first time, so there is a large wound over here and night pain, and after 2 months follow up, the ulcer size is reduced, which is very quietly visible on the follow up. Pain is reduced. Still I feel little bit warm. Me and Rosie have done the second sitting also, and right now completely pain is gone. So don't rely only on medical treatment for chronic wound management also. If they are not responding, then go for MSK embolization. And MSK joint embolization technique is very helpful for many patients, and particularly if you have seen this conference like heel pain, Achilles tendinopathy, like tennis elbow, there are not much surgical options are available. For larger joint, for knee joint, there are option of knee replacement surgery is available. It's a last choice. But for such kind of ankle joint, many patients we have done with the chikungunya infection, they have ankle pain, and you cannot replace the ankle joint, but patient is still suffering from the pain. Like this patient is suffering from elbow pain since 10 years, and everything is tried, but not responding. And all the joint pain, once if we confirm that there is a inflammatory pain, and if we apply this technique into that joint, then it is really helpful. One more important thing, many patients ask us that can we treat the back pain, or can we treat the sciatica pain? So I would always tell them that the origin of pain is different. When we are treating the sciatica pain, the pain origin is due to the prolapse intervertebral disc. So that is the neurological origin, and this treatment is not helpful for neurological pain. This treatment is helpful for chronic inflammatory pain. So particularly all the joint pains can be treated with this MSK joint pain embolization technique. Thank you so much.
Thank you, Dr. Mohal Bankar, for such an informative session. Our next speaker is Dr. Nisarg Thakkar. He has done his post-graduation in radiology and fellowship in interventional radiology. He has joined Dr. Rosil Gandhi's team and has keen interest in carrying out uterine artery embolization, which is a very useful non-invasive technique for treating uterine fibroids. I would like to invite him on the dais.
Good afternoon, everyone. So today I am going to talk about uterine artery embolization. So what are the indications? Uterine fibroids causing menorrhagia, that is heavy uterine bleeding, pelvic pain and pressure symptoms, fibroids with otherwise undiagnosed infertility, and as a preoperative measure for large fibroids. Another indication is uterine AVM, that is because of the trauma and post-curettage. Now what are the contraindications to uterine artery embolizations? The first contraindication is contraindication for angiography, that is having previous anaphylactic reaction to contrast media, Other contraindications include pregnancy, active pelvic infection, and prior pelvic radiation. Now, what are uterine fibroids? They are benign smooth muscle tumors of the uterus. The smaller tumors are generally asymptomatic, but larger tumors can cause pain, heavy uterine bleeding, and pressure symptoms. So, risk factors for the uterine fibroids include a high level of estrogen and progesterone that occur in breastfeeding women and pregnancy and perimenopausal individuals. So, there are basically three types of uterine fibroids. The first one is submucosal, that is within the endometrial cavity. The second one is intramural, that is within the uterine wall, and third one is subserosal, that is under the perimetrium. So what are the treatment modalities? So non-surgical treatment modalities include uterine artery embolization. The second one is MR guided focused ultrasound surgery. The surgical treatments include surgical removal of the tumor, that is myomectomy, and the other treatment is hysterectomy, that is surgical removal of the whole of the uterus. So now, how does uterine fibroid embolization work? So we basically block the uterine artery that supply the fibroid that causes them to shrink. It's a minimally invasive technique. We do a tiny nick of incision at the groin, and we take the uterine artery angiography, and we identify the vessel supplying the fibroid, and we inject the tiny embolization material, that is PVA, and we block the vessel. And patient is conscious, and we give painkillers, and there is no need of anesthesia. So this is a diagrammatic presentation. So we puncture the femoral artery, and we take the angiography of both the uterine arteries, and we identify the vessel supplying the fibroid, and we superselectively cannulate the artery and embolize using embolizing material. So benefits of uterine fibroid embolization: there is no need of longer hospital stay. Generally, it needs lesser 1 day of hospital stay. Patient can be discharged in 24 hours. Many women resume their light activities from the very much next day, and they can return to normal activities within 7 to 10 days. 90% of the women who had procedure experience significant or total relief of heavy bleeding. 85% patient is conscious, no need of anesthesia. The benefit of uterine fibroid embolization over hysterectomy: there is a lesser hospital stay, recovery time is very faster, and the complications are very less. The risk of uterine fibroid embolization: it includes moderate to severe pain just following the procedure. After following the procedure, and other complication includes nausea and fever that can be managed by non-steroidal anti-inflammatory drugs. Infection can occur that can be managed by antibiotics, and there is 1% chance of fibroid expulsion. What do I have to do after the procedure? Generally, anti-inflammatory drugs are prescribed following the discharge. Patient can start their normal activities within 6 to 7 days and can come for a checkup after 1 to 6 months. So we will go upon the cases. The first case: 29-year-old female came with a heavy uterine bleeding, and MRI was advised. MRI shows arterial hyperenhancing lesion within the endometrial cavity, and 3D angiography showed arteriovenous malformation. So we did an angiography. Angiography of the right uterine artery showed hypervascular blush and early venous filling, that is arteriovenous malformation of the uterus. The superselective cannulation of the AVM was done and was embolized using PVA particles, and post-embolization picture showed no residual filling. The second case of 39-year-old female presented with multiple large uterine fibroids and having menorrhagia and pain. So uterine fibroid embolization was done. This is the angiogram from the bilateral iliac arteries. It showed large area of tumor blushes from both the uterine arteries. The superselective cannulation of the left uterine artery was done and was showing large area of uterine fibroid, showing large and hypervascularity. So it was embolized using PVA particles, and post-embolization angiogram showed no residual hypervascularity within the lesion. Similarly, right uterine angiogram was taken, which also showed large uterine fibroid. It was embolized, and post-embolization angiogram showed no residual hypervascularity. This is the final bilateral iliac check angiogram, which showed no residual hypervascularity supplying the uterus. This is the last case, 34-year-old female, operated twice for the myomectomy done. Second time adhesion lysis was also done, but patient still having multiple fibroids. So angiography done. A pre-embolization angiography of the left uterine artery showed large area of hypervascularity from the left uterine artery. So embolization done, and the post-embolization angiogram showed no residual hypervascularity from left uterine artery. Similarly, right uterine artery angiogram taken, and it showed no residual, after embolization, no residual hypervascularity seen. So uterine fibroid embolization is a very useful technique. It's a less invasive with a lesser recovery time, and so patients can start their routine activities within few days as compared to hysterectomy. Thank you.
Thank you, Dr. Nisarg. In the last session, before moving further, I would like to express my gratitude to Magical Formula and team for organizing such a wonderful conference. Thank you and have a great day. Now I would like to call on dais Dr. Rosil Gandhi for delivering the topic prosthetic artery embolization, followed by vote of thanks.
Good afternoon, everybody. So I'm standing before lunch. Last topic, as I have mentioned, intervention radiologist, we have something for every organ, and for prostate also we do the same. We embolize the prostatic arteries. So use of prostate, it is a vestigial organ. And what is benign prostatic hyperplasia? So above 50 years, every male has a mild or minimal or of some degree of prostatomegaly. So benign prostatic hyperplasia is a non-cancerous growth of transitional zone of prostate which surrounds the prostatic urethra. So when it becomes enlarged, it compresses the urethra and causes various symptoms. The various symptoms which it causes, it is called LUTS, lower urinary tract symptoms, and bladder outlet obstruction. It significantly degrades the quality of life in an old age male. It is divided into two parts. The symptoms are divided into two parts, irritative and obstructive. Management, the most common management is alpha blockers, medical management. Second is TURP, and we have placed prostatic artery embolization in between. It is a minimally invasive therapy. So how to evaluate a patient with prostatic enlargement? Symptom evaluation by objectively is by IPSS score, that is International Prostatic Symptom Score. Per rectal examination to whether the prostate is hard or soft. If the prostate is hard, basically we have to rule out malignancy. Serum prostate specific antigen levels, PSA levels, to look for malignancy, and routine blood investigations. MRI prostate or a CT angiogram depending on the previous examination, if we are suspecting anything abnormal. This is IPSS score. It is based on the symptoms of patient, whether the patient has incomplete emptying, how is the frequency levels of in the night, how is the frequency of passing urine, whether the urine passing is intermittent, how is the urgency level, how is the stream, and how much patient has to strain. So based on this multiple symptoms, we are giving points to all symptoms, and IPSS score is calculated. 0 to 7 points, the score is mild symptoms, and above 8 to 19 it is moderate, and higher are severe. Prostatic artery embolization has emerged over a last period of 5 to 7 years as a truly minimally invasive treatment option for patients with lower urinary tract symptoms because of benign hyperplasia. It is not used for prostatic malignancies. So there are multiple evidence-based guidelines now and multiple papers and trials proving importance of prostatic artery embolization. Indications, it is BPH with refractory LUTS or intolerance to medical treatment. Contraindications or patient's refusal to surgery, indwelling Foley's catheter or urinary retention. It can also be done for hematuria with bleeding from the prostatic gland. I'll show two cases. 68-year-old male, history of hematuria since 4 days, no history of trauma, fever or any procedure. CT showed a small aneurysm in the prostatic artery in the prostate parenchyma. So this is the CT picture. It shows a small pseudoaneurysm in the prostate, which was picked up on angiographic image. So this is the inferior vesical artery and this is the prostatic branch. So this is the pseudoaneurysm which we have embolized. These are the embolization material in the prostatic artery. Procedure is done under local anesthesia. As I mentioned previously, it is a safe pinhole technique, minimal complications. CT is performed in the cath lab itself to identify the prostatic arteries and to protect the bladder base from getting necrosed because of the embolization particles. So CT in the cath lab is very important. Studying the anatomy and the branches of internal iliac artery and to select the right branch is also very important to select the right view. We go with the 4 French 5 French sheath and 1.3 millimeter is the 4 French diameter. So this is a schematic diagram showing the bilateral prostatic artery and we embolize it by injecting small particles. So this is what the particle looks like. Post procedure immobilization is for 6 hours and patient can resume normal activities after few days from the next day. Again another patient, left side prostatic artery, this is the prostatic blush. Similarly left side prostatic artery and this is post embolization. You cannot see the blush. So what happens is the prostate becomes necrosed, so it becomes inactive and the pressure symptoms reduce and there is 25 to 30% improvement in the IPSS score in first 3 months. This is right sided prostatic artery. Benefits, it is minimally invasive, lower risk of urinary incontinence, no sexual side effects like retrograde ejaculation that is seen in TURP, less pain and discomfort during and after the procedure. Criteria for symptomatic improvement are defined as IPSS score of less than 18 with a decrease of at least 25% and quality of life score less than or equal to 3 and at least 1 point decrease compared to the score at baseline. So IPSS score helps in evaluating the embolization procedure. Clinical failure if the score has become more or there is persistence of severe symptoms. Embolization shows a success rate of 80% at 6 months and 75% at 12 months. Recurrence rate are higher than the surgery, but it is a minimally invasive. It can be done once again if required, and it is a procedure with minimal risk. Side effects, non-target embolization. If the embolization is done to other arteries, then there can be side effects. And other side effects of angiography like femoral artery bleed. So all side effects are less than 3%. So this is how a prostate looks before, how it looks after TURP. The prostatic urethra size increases, and this is how the prostate looks after embolization. The size of the prostate has reduced, the urethra is normal. Follow-up with the clinical findings and imaging findings. IPSS score is evaluated and MRI can be done if required. Thank you. At the outset, and I would like to thank everyone. First of all, Dr. Keyur Patel and Mr. Nilesh Soni of the Health One Hospital for providing the platform. Second, Rushi and Deepak Bhai for very good software and everything. Speakers, Bhavesh sir, Jitendra sir, Dhrushi, Ankurbhai, Gaurav, and audience who have seen and who are going to see. Thank you, everybody.